Is the lady talking? Give her my clip.
Yes.
Nazareth, can
Yes.
you tell me how to pronounce your last name?
Jendi.
Good morning, everyone. Good morning. Okay, good morning. Welcome to our first day of scientific sessions during our second annual, but first in person, DSI Africa Consortium meeting. For those of you who I haven't had a chance to meet yet, my name is Brad Newsome. I'm a program director at the Fogarty International Center at NIH and the program officer overseeing our research hubs. I feel like I should provide a little bit of congratulations to you all in the room for those of you who actually made it to an 8:30 scientific session. We're a little sparse still, but thank you all so much for being here for this great start to what I think is going to be a really important discussion, especially knowing what we've been discussing over the last few days. I can say that, at least personally, I've seen so much enthusiasm from this group, certainly within our team at NIH and across the consortium. I see people engaging as a research team, some of you for the first time all together in person since the pandemic. Of course, many of us have met each other on Zoom, but it just does not take the place of being here in person. So thank you all so much for your engagement in this really important first meeting together for forming relationships, talking about great science, and pushing us forward over the next 4 years of this consortium. When thinking about transformational collaborative work, it's not for the faint of heart. I think we all recognize that. It's not simply about the science. It's also about the legal and cultural implications. It's about overcoming a host of barriers for effectively sharing information. So I think that we all saw, for those of us who attended the Datathon, for yesterday morning's sessions around our working groups, yesterday afternoon's opening session, I think effective inter-country as well as cross-border data sharing has been on the top of pretty much everyone's minds about how do we do that effectively, ethically, legally, overcoming a host of governmental barriers, not just the expectations of a grant like you have, but so many different barriers that we're discussing right now, how we're discussing policies around within our consortium, but also its implications so much more broadly. So for our first scientific session, we're highlighting the vital role of cross-border data sharing for harnessing data science, for pushing forward health in Africa. We have a diverse group of early career and established investigators that are joining us from the DSI Africa Law, the REDS SA, the CAMERA, and the MUDSRA teams across the DSI consortium to walk us through where we currently stand and where we're going with regard to African data sharing. Each of our scientific sessions will be designed slightly differently to keep things interesting, hopefully to keep everybody awake. And we have a little bit of time after each of our sessions, each of our discussion points, for a little bit of Q&A. But if you don't have enough time for Q&A, don't worry. We'll have a panel discussion at the end of this session where everybody will be out here to take some facilitated and some questions from the audience. First off, we're going to start our session with a broad overview of data science and data sharing in Africa with a broad vision for data sharing moving forward across the continent. We'll then discuss the vital role of stakeholder engagement in informing data sharing needs. We'll then move on to discuss the vital role of data standards and legal clarity for in-country and cross-border data sharing. Then we'll discuss some tools already developed to push forward effective data sharing. And then we'll finish our session's presentations with what is being developed across the DSI consortium and moving us forward through the next 5 years. We'll then finish our session with a Q&A session with a panel discussion to get us really discussing all of the challenges, but also all of the incredible opportunities that come from cross-border data sharing. So with that, I would like to introduce Dr. Lukman Abdul Rauf, who's a senior lecturer in the Department of Public Law and Faculty of Law at the University of Ilorin in Nigeria as our first speaker. He is currently a fellow at the Center for Advanced Study in Behavioral Science at Stanford University in the US. He is also an honorary research fellow at the University of KwaZulu-Natal in Durban. Luckman has an LLD in law with a specialization in data protection law, with research interests also in digital rights and digital constitutionalism. He is a co-investigator of the DSI Africa Law Program, leading their research on cross-border data sharing. Welcome, Luckman.
Good morning. Thank you very much again for the opportunity to speak to you on this very important topic. I am coming to present to you a vision here on cross-border data sharing, or a vision towards promoting health research in Africa. As Brad has mentioned earlier, I belong to the DSI Africa Law Group. We basically focus on, we are not scientists, we basically focus on investigating the legal issues that arises in the use of data for the purpose of health research or for the purpose of health discovery and innovation. These are some of the things we do basically, or these are some of the things we are trying to investigate basically, and across the aims or our major aims, you find the aim which I lead, which is basically facilitating cross-border data sharing within the continent. And as you see, as I'm going to say today, my discussion basically looks onto how, or looking at it from a regional perspective or from a regional context, how to ensure, how to facilitate cross-border data sharing in Africa. I will be looking, this is basically going to be the outline. I'm sure I'm not going to speak for up to the 20 minutes I have. I have a brief introduction and the state of data sharing in Africa. I'll just focus on the challenges. I will not really emphasize more on the state of data sharing. Then I'll speak some details about the vision, the African Data Corridor vision. And I'm going to also go into looking at what are the possible obstacles that could arise in realizing the vision of an African data corridor. And finally, I'll conclude. Now, in the context of this discussion, I don't think I need to come and start to re-emphasize the importance of data sharing in Africa, or the importance of health research in Africa. And of course, also, I don't need to come and start to restate the not so significant role that Africa has played in terms of scientific research, innovation, and discovery in Africa. I know things are beginning to change recently, but before now, we have not really done so much in terms of participating significantly for scientific discovery and innovation. Especially in the context of genomic research, we heard yesterday that Africa is just coming up in this regard, and of course that's a good thing. You see some recent improvements with projects that have been supported, or projects that have been supported by partners, the DSI Africa Law Project, the H3 Africa Law Project, and so on, towards ensuring that we also stand up, or we're also able to participate significantly in terms of scientific research, discovery, and innovation. A lot of literature have confirmed the fact that intra-African research collaboration and data sharing are yet to be at the optimal level. Again, for the purpose of my discussion, I am basically focusing on intra-African research, how we collaborate with each other, or how we share data with each other within the continent. I think we should first of all focus on how we are able to help ourselves before we start to think about how we can participate, or how we can effectively collaborate with partners outside the continent. And of course, that has to do with a discussion on Africanization of health research. When we talk about Africanization of health research, we basically focus on how Africa can move towards bringing about solutions to its own problems or to its own based on its own peculiar circumstance. Now, in terms of the state of data sharing in Africa and the challenges, like I said, I'm not going to so much emphasize on the problems of data sharing. I'll focus particularly on one aspect, which basically has to do with our specialization or what we do, and that has to do with the legal challenges. Before now, the space has been dominated by ethicists who probably are providing the norms with regards to data sharing. But now we have a new guy on the block, so to say, and in the context of data sharing, you cannot ignore the role and the force of data protection laws. You have to ensure that you comply. Scientists must, as much as possible, as much as they're trying to comply with, or as much as they're trying to satisfy the ethical requirement based on the research ethics committees, guidelines, and so on, or codes, they also have to satisfy, or they also have to fulfill the requirement of data protection laws when it comes to data sharing. And that sometimes could be a challenge. You see a lot of discussions around the fact that data protection laws could even be a data localization policy, or a data localization measure in as the case may be. So basically, what are these legal challenges? One of the legal challenges has to do with the difficulty and complexity in complying with multiple legal frameworks. In the course of our research, there's this in terms of the use, or in terms of sharing of data that involves identifiable data or personal data, there's a complexity of complying with a whole lot of laws, not only health research laws or health laws. You also have to think about the complexity of complying with data protection laws. And data protection laws could be a bit complex, especially for scientists who want to carry out research. So basically, this is one of the challenges, and it is my hope that the vision will be able to take care of this challenge. And there's also the issue of the adequacy requirement. Adequacy, as you may know, is a requirement that is brought forth from the European Union Directive on Personal Data Protection that says that for data to move out of the EU to another country, it has to satisfy, or the other country must have that adequacy requirement. My purpose for bringing it here as a challenge is not so much as to speak about it from the European context, but to talk about it from the fact that many African countries are also having this kind of provision in their data protection laws. So if you are dealing with personal information, if you are dealing with data that is personally identifiable, you must comply with this requirement. You have South Africa, you have Nigeria, you have Kenya, and so on, all having this adequacy requirement for you to move data from one country or from the home country to another country. The other country must have adequate data protection laws in place. So this can be a challenge for health research, because for some countries like South Africa, not only do you need the requirement of adequacy, you also must sort the authorization of the information regulator, especially when you need to transfer data out of South Africa, or if that data is considered to be sensitive data. There's also the problem of lack of convergence or interoperability of health and data protection laws. Like I mentioned before now, what used to be the main governance frameworks was health laws. When you see most of the works, most of the researchers or most of the authors will actually focus on how health laws, or basically health research ethics codes and so on. But now, data protection laws have come into place, or data protection laws are enforced in, I think, about 36 African countries now. So we can't but help, or we just have to ensure that we not only comply with the ethical requirements to satisfy in terms of use of data, but we must comply with the requirement of data protection laws. Then there's also the issue of lack of harmonization at the regional level. Like I mentioned at the onset, my aim is to ensure we promote intra-African research. But then we have different cultures, different legal systems that coexist among themselves. And sometimes this also reflects in our data protection laws, and it might bring about difficulty, it might bring about complexity in the sharing of data. So this could be a challenge. Another also emerging trend in the course of our discussion, in the course of our research, which we have found, is the increasing development of data localization laws and policies in Africa. Nigeria has a data localization policy and so on. I think South Africa too also has a data localization policy. Basically, when we talk about data localization, we are talking about a policy that is in place to see to it that certain category of data do not move outside the country. And of course, you agree with me that this could be an obstacle to health research in the context of advancement of health research. The last challenge I've identified may not necessarily be a legal challenge per se, but in the course of our discussion on the African Data Corridor, we're also going to touch on the issue of digital infrastructure. Now, the lack of harmonization of digital infrastructure, we don't really have a centralized, I think yesterday we mentioned it, of whether we need a centralized infrastructure or we need a decentralized infrastructure. And so in the context of health research, some will argue that a centralized infrastructure where researchers will be able to access health information could probably be preferable. And that is something that is lacking in Africa, probably owing to the level of development in the country, the level on the continent, the level of technological development, and so on, or probably as a result of the level of or the complexities that has been brought about by the legal frameworks and so on. So at the end of the day, it's my hope or our vision towards the African Data Corridor will look onto how to take care of these challenges so as to facilitate the free sharing of data between researchers, or the free sharing of health data between researchers in Africa. So now towards an African data corridor. Sorry. Now, in the course of this, the idea actually came up from a researcher in our group where she published a paper. I think this is the paper, The Lawful Sharing of Health Research Data in South Africa and Beyond. And in the course of this data, even though the article focuses on South Africa, she identified what are the main challenges with sharing of data between South Africa and other countries, especially health research data. Now, these are some of the recommendations that came out of that particular research: to streamline data flows within Africa, to promote regionalism and regional integration, to promote health research in Africa, again, and Africanization and cross-border data transfer, basically to promote Africanization and cross-border data transfer. Of course, from the work, you'll also see an attempt to push for a Pan-African agenda in the discussion of, or within the context of the debate on cross-border data sharing, especially considering the fact that many African countries are now trying to embrace, or many African countries are now trying to key into, or are trying to subscribe into genomic research on the continent. Now, in the course of this work, of course, Dr. Townsend recommended that we should try to look into the possibility of opening up an African data corridor that will ensure the free movement of health research data within researchers or between researchers in Africa. And of course, we believe that not only will that corridor be able to do what she has recommended, but it might also be able to do more, in that it will facilitate cross-border data sharing between African research institutions and research institutions outside Africa. Now, in the course of this, one institution always surface, or one institution will always come to mind when we want to do anything, or when we want to do, or when we want to promote an idea that looks onto an Africanization idea. And of course, that institution is the African Union. So we cannot talk about, in our view, or based on our ideas towards the African data corridor, we cannot talk about this in isolation of the African Union. And of course, the reasons are obvious. The best representation at the regional level, almost all African countries belong to the African Union. They subscribed, they've ratified, so to say, the African Union Constitutive Act. And of course, the power to harmonize other regional bodies. So it's not all about harmonization at the domestic level, bringing together countries at the domestic level, but also bringing together the sub-regional blocks, ECOWAS, SADC, East African countries. It's EU that has that power, and that is why we feel our vision of the African data corridor should actually be situated within the context or within the powers of the African Union. I probably did not go so much into bringing out particular provisions of the African Union Constitutive Act that is in support of this idea, even though not directly. But you see the African Union Constitutive Act also in support of trying to promote integration at the regional level and at based on various subject-specific areas. Now, to further make my work easier, to further confirm our vision, we have the African Union Data Policy Framework 2022. And when you see that document, you see that one of the visions of the African Union is to promote an idea, such as an idea of an African data corridor. You see it making statements like the importance of harnessing data, promoting research for development, and particularly you see statements, I think the last paragraph, support the development of regional and continental data infrastructure to host advanced data-driven technologies such as big data, machine learning, artificial intelligence, and the necessary enabling environment and data sharing mechanism to ensure circulation across the continent. That's also provided for in the African Union Data Policy Framework. And of course, still, when you see the body of that framework, you also see that it is among the objectives of that framework to promote health research or to promote the sharing of data in the context of health research. So I feel, or we feel, that the African Data Corridor is properly supported by the recent African Union Data Policy Framework. Now, still on the African Data Corridor, our idea is that we should have a purpose-driven vehicle towards, again, promoting intra-African health research, towards facilitating cross-border exchange of data in a manner that is going to probably overcome some of the legal obstacles that have been put in place by the legal of the domestic institutions in Africa. And of course, again, drawing ideas from the European Union approach, it will provide for what we call the African Data Single Market, or the DSM, which operates in the United Union towards harmonization. I know we can argue that the European Union is a more harmonized institution than the African Union, but then we need to actually start somewhere. We need to do something in this regard. Now, what are the main principles that is going to guide this vision, especially in the use of health research data, or in the use of health data? We have the principle of fairness and lawfulness, transparency and openness, sovereignty, integration and cooperation, comprehensiveness, non-discrimination, trust and security, especially trust and security. And that one is going to have to do, that one will focus more on the infrastructure which we are going to do. And like I've mentioned, it will help probably surmount the obstacles which have been placed on the sharing of data by data privacy laws and some other policies in the country. This is still some more ideas or some of our own vision of how it is going to look like. Now, with regards to the corridor, this is what we envisage it's going to be a probably harmonious relationship between an institution, or first a legal framework, an institution, and an infrastructure to ensure or to facilitate the sharing of data at a continental level. And you see my emphasis on the legal framework, the legal framework, the legal framework. The emphasis on the legal framework is because of the fact that now you cannot deal with health research data. You cannot deal with health data without complying with the laws, whether at the regional level or at the national level. So we cannot close our eyes, we cannot close our minds to the legal framework in terms of cross-border data sharing. So this is a picture of what we envisage will come up with. Like I said, it's just a vision. We are trying to develop this, and we're hoping that we're going to develop this further in the course of our research. Now, what do we have with regards to the legal framework? Again, we have a continental data protection framework in Africa, the African Union Convention on Cybersecurity and Personal Data Protection. I will not come and stand here and say we should discard what we have. We have to look for how to build upon what we have. So my vision, or our vision in this regard, is that we should probably have a protocol to this convention which promotes, or a protocol to this convention that specifically has to do with the dealing, or that specifically has to do with cross-border data sharing or cross-border sharing of health research data. And there's a reason why we need this normative framework. The reason why we need this normative framework is that when you look at the provisions of most data protection laws, they talk about the need to ensure a sort of affiliation, a sort of regionalism, or a sort of connection, so to say, between the domestic laws and the regional laws. So it's not probably out of place for us to have this at the regional level. There's going to be that connection. And if you see recent events in the African continent, you see that even the data protection authorities in Africa are trying to come together towards bringing about harmonization, towards bringing about integration. I think probably you might be aware of the Association of Data Protection Authorities in Africa, which is doing quite a lot in terms of harmonization. So we are recommending a protocol, and the reasons why we are recommending a protocol to the African Union Convention is because the African Union Convention is too general in nature, and in dealing with health research data, there are certain peculiarities, there are certain specificities that we feel that a protocol will effectively take care of. So the protocols, of course, is going to contain principles that are aligned with the African Union Convention, and of course, such an approach is also supported, or such an approach is also contained in the African Data Governance Policy, or in African Data Governance Policy framework, where it speaks about developing at the regional level sector-specific and specialist data code. Now, there's a reason again why we selected the protocol, why we selected a protocol among the legal instruments, one of which is the bindingness. You need something that has the force of law for you to be able to deal in this kind of information. You need something that has that force of law for proper integration or proper enforcement. Now, not only are we speaking about a legal framework, we're also speaking about an institution. And the institution we're recommending, or the institution we envision, is an institution that will not only be a collection, or that will not only be an association of data protection authorities. It's an institution that is going to bring about harmonization, or probably a healthy working relationship, so to say, between health research authorities, or health authorities, and data protection authorities. In the course of our research so far, we have found that that lack of integration, or that lack of I don't want to use the word coherence, or that lack of harmonious working relationship between data protection authorities and health authorities, or health research authorities, does no well for the free sharing of data. So our recommendation, you should have data protection regulators serve as members of this committee. You should also have members of almost all, or most African countries have health research ethics committees at the national level, which is affiliated to the ministries of health in the countries. So you should have representatives of these work together, and I think it's going to bring about, it's going to eliminate some of the issues we have with regards to fragmentation. In the course of this, you'll notice that we are a bit cautious not to recommend a more permanent body. We want a committee because of probably Africa's approach towards permanent institutions and so on. Besides, it's just a vision, and I think that it's good to start with, or it's good to take baby steps towards realizing this. So we recommend a committee rather than a permanent body. With regards to infrastructure, I know as a matter of fact that many African countries are working hard towards harmonizing health data. Many African countries are working hard towards developing electronic health records or electronic medical record databases and so on. So what we're asking is that probably at the regional level, we should look onto how we can harmonize this body, or we should look onto how we can try to harmonize some of these initiatives or some of these developments to create a sort of a central platform that will enable the access to health data, that will enable access to health data by researchers. And of course, it should have national contact points and so. This kind of idea is not new to Africa. Recently with the COVID-19, we had the initiative called the Trusted Vaccines that sought to bring about harmonization in terms of ensuring the easy movement of people, developing travel certificates or COVID certificates and so on. And from what we have seen, it seems to have been a partially successful attempt at harmonization. So it's not a strange idea to Africa. It's not something that should look so foreign to Africa. Now, in a discussion on the African Data Corridor, of course, it cannot be in isolation. There must have been inspiration, or probably you must have seen some elements of its workings in other places. There's the Global Alliance for Genomic and Health, Alliance for Genomic and Health. That one just basically is an initiative that brings about a framework, a voluntary framework that organizations can subscribe to. And of course, it seeks to bring about easy sharing of data for members or for institutions that are ready to subscribe to it. In Africa too, there's the East African Health Research Commission. Even though it has not concentrated so much on data sharing, you see that it has, when you see the purposes or the functions of this body, you see that one of the main objectives is to bring about this sort of harmony we are talking about. So it's probably not strange, and I think it is workable for Africa. But most recently, there's the European Health Data Space, which seeks to create a platform that is similar to our idea of the African Data Corridor. And it tries to harmonize at the European Union level the use of data for healthcare and for health research. So we believe it's actually workable. We believe that it's something that we can try to achieve. Now, what are some of the possible obstacles to this vision? The complexities of regional integration. We know that the AU is doing so much. The AU is making so much effort, but still we must acknowledge the fact that integration at the regional level is a challenge, and integration at the regional level is, so to say, a complexity, so to say, which African Union is working towards. But I think, in my view, I think things are actually getting better recently, and it is hoped that we will be able to overcome some of these challenges. Then there's also the conflict between local data privacy laws and the proposed health research. And I particularly reflected on this challenge because when you look at some data protection laws, I don't really have an example in my hand, but I think it's one of the data protection laws we're working on in the course of our project. You see, it makes reference to the fact that in terms of dealing with personal data or health data, every other norm must be subject to the data protection law. So you see this kind of provisions in data protection laws. But then we're not recommending a framework that will come and be totally different from what we already have, or what we have that is going to, or what currently exists. We're looking for something that is going to work harmoniously, both at the regional level and at the domestic level, since we have the participation of data protection authorities and so on. Even though the concept of privacy and so on is not so developed in Africa, there is the fear of big data in Africa. And I think that should also be a fear, or that should also be an issue that we should also reflect upon. But in terms of development of the infrastructure, based on the lessons we have drawn from the places we have gone to draw lessons, you find out that they have been able to develop an infrastructure that is foolproof, so to say. Of course, there's nothing that is foolproof, totally foolproof, but we'll also make our attempt. Everything we use probably have its own challenges, but we only recommend that we should make our own attempt to ensure that we have this thing completely, or we have it foolproof, to give that level of trust in it. Then the political will, which is very important, we mentioned it yesterday. We need to have, there's need for that political will to be able to make this vision drive. I'm just running out of time, and I think I need to conclude. Our concluding remark, I think we need to start from somewhere. We cannot continue to probably sit and talk and talk, and we need to actually start from somewhere. And some members of my group have recommended that, probably because of the issue of the harmonization at the regional level and the differences in cultural orientation, or the differences in approaches of different countries, probably we can have a situation where a few African countries will drive this initiative, and from there we will be able to make progress with this. I think I'll stop here, and I look forward to further discussions on this. Thank you very much for the opportunity.
Write down your questions. Let's move forward just in the interest of time. But again, we will have time later on during our panel discussion. I'm sure that you have many questions for Luckman, so please do that. Next up, we are moving on to the very important area of understanding what stakeholders need when in informing our research, informing how we are moving forward across Africa to make sure that what we're doing is valid, it's legal, it's informed. So first up, we have two speakers around engaging key stakeholders for informing African data sharing. And in the interest of time, again, I will turn you all to the bios on the website for everybody, and you please look forward to that. But Dr. Nezreth Cengiz from the Center for Medical Ethics and Law in the Department of Medicine at Stellenbosch University in South Africa, and a research assistant with the REDS SA team, as well as Dr. Stuart Rennie, who's an associate professor at the Center of Bioethics in the Department of Social Medicine at the University of North Carolina, Chapel Hill. Nezreth, welcome.
Good morning, everyone. My name is Nezreth, and today I will be presenting the main findings from our recently conducted empirical research. I am joined by our co-PI of the Red Sub project, Professor Stuart Rennie, who will discuss our results at the end. So our presentation is titled Engaging Key Stakeholders for Informing African Data Sharing. So here's an overview of the presentation today. We will start with an introduction and end off with commentary. So our study aimed at exploring perspectives on data access, sharing, and protection in sub-Saharan Africa, specifically the perspectives of REC members, also known as IRB members, as well as data scientists and researchers. We selected these peer-level stakeholders because of their exposure to data sets and data-intense research protocols. Our specific aims included identifying which sub-Saharan countries have frameworks and guidelines, identifying and describing data governance-related challenges faced by these stakeholders, and exploring their perceptions and their previous data sharing experiences. So we used a descriptive cross-sectional survey for each stakeholder group and ran each survey for 3 months each, April to July for the REC member survey and June to September for the data scientist and researcher survey. Our study population was selected based on REC membership and data scientists and researchers that are involved in data-intense research. So for REC members, our survey instrument consisted of 20 closed-ended questions, of which 4 of which were conditional, and for the data scientists and researchers survey, our survey instrument consists of 14 closed-ended questions and 1 open-ended. So both these questionnaires were made available on REDCap, and we translated both these questionnaires into French and Portuguese. For both questionnaires, responses were exported from REDCap and exported into SPSS for analysis. Frequencies and percentages were used to describe responses to closed-ended questions, and also answers from open-ended questions were manually analyzed by a trained researcher. So here are 2 maps. We just wanted to visualize a little bit. So the green indicates the countries that we managed to get a response from, and the red countries that we didn't manage to get a response from. So the first map is for the REC member survey, and second map for our data scientists and researchers. So as you can see, we were able to cover more ground for the data scientists and researchers. So as I mentioned, we conducted 2 surveys. So for our REC survey, we received 140 responses from the 300 individuals that we invited to participate, yielding a response rate of 46.6%. And the total number of respondents from the survey represented 34 of the 49 sub-Saharan countries. Then for our data scientists and researcher survey, we received a total of 160 responses from the 321 individuals that we invited. So for this group, our survey represented 43 of the 49 sub-Saharan countries. So we managed to reach almost 3/4 of sub-Saharan Africa. So I will just present some of our key findings for the REC survey, and then I'll move on to do the same for the data scientist and researcher survey. So 58.6% of participants or respondents reported having national laws on research data protection. 68.6% reported having institutional policies on research data protection. Then for restrictions on trans-border flow of research data, 47.9% reported having national restrictions and 50% reported having institutional restrictions. So regarding perceptions, 45% of respondents expressed the view that their national laws on research data protection are adequate, and 51.5% of respondents expressed the view that the institutional policies on research data protection are adequate. Then we asked the same question for trans-border flow of research data. 40% of respondents felt that the national restrictions are adequate, and 40.8% felt that the institutional restrictions are adequate. Then we asked some questions around support systems for REC members. 77.8% reported having no appropriate institutional ethics guidance on the protection of research data and human or biological material. 14.3% reported receiving no training regarding the review of data sharing protocols. Regarding challenges, 63.6% lacked experience in reviewing data-intense protocols, and 70.7% felt that data sharing could be better regulated. So a suggestion to improve the regulation of data sharing, some suggestions that came up were implementing data access committees. So we asked respondents whether their institutions had data access committees, and 63.6% reported no. Now moving over to the data scientist and researcher survey, 76.3% reported generating their own data, 51.7% reported that they make their data available through informal sharing, for example, email, Dropbox, OneDrive, etc. And 32.5% reported that they make their data available on their organization's website. 88.2% indicated that they would make their data available if conditions of governance and regulation on access apply. So for those that indicated that they do not make their data available, we wanted to know why. So the most common reason is that lack of frameworks that make it mandatory to share. Second to that is insufficient funds to make data available. And the third most common reason is don't have the right to make the data available. Then we asked some questions around satisfaction with data practices. Most respondents reported satisfaction with their institutional processes for long and short-term data storage. Respondents also reported satisfaction with the data tools used for the preparation of documentation and metadata. We also asked some questions around perspectives on the reuse of data, and majority of respondents supported the idea that data may be used in other ways than initially intended. Majority of respondents also indicated that the lack of access to data generated by other researchers or institutions has restricted their ability to answer scientific questions and is a major hindrance to progress in science. So around the conditions for data sharing, I just want to highlight that more than half of our survey respondents agreed to exchange their data for royalties. More than half disagreed to exchange data for profits, and again, more than half agreed to exchange data for the recovery of a portion of the cost of data acquisition, retrieval, or provision. So, in conclusion, our results indicate variability in data governance and regulation in sub-Saharan Africa, as well as variability in REC members' perceptions of the adequacy of their national laws and institutional policies. Our results indicate that data scientists and researchers require frameworks and policies as they are currently lacking. So it would be needed in order to promote data sharing in sub-Saharan Africa. There is a unanimous expressed need for REC member training and the development of data access and sharing policies. So this study has drawn out perspectives on data governance from 2 stakeholder groups and has also raised awareness of the importance of data governance in research. The expressed need for guidelines and training will inform current and future outputs of the RETSA project. And we are also currently analyzing data from our in-depth interviews. We have managed to conduct a great number of in-depth interviews across sub-Saharan Africa, and once that information is available, we can share. So I couldn't present that information today. So both LC projects and research hubs can contribute to capacity development of REC members and researchers. And it is important to remember that having laws and policies is important, but awareness, understanding, and implementation of those laws and policies are even more important. So I just quickly want to acknowledge first and foremost the NIH, of course, and also Professor Kimantri Moodley, our PI for the RETSA project, and the rest of our team who contributed to this research. So I will now hand over to Professor Stuart Rennie, who is a co-PI of the RETSA project, for commentary.
Okay, I'm not a survey researcher. I'm actually a philosopher. So I'm going to go old school on this. I don't have any PowerPoint slides. You can continue to look at this one if that's what you're really into. So just to, give some reflections on the study that was just presented to you. These are obviously two stakeholder groups that are key to the success of data science in Africa and the potential that it has for health promotion. Both of these stakeholders groups, you could say, looking through the data, that they're challenged in certain ways. Some ways that are different for each group and some ways that they have in common. When looking at the research ethics committees, the awareness that's shown through the survey data, their engagement with the survey itself, and you could say even the existence of research ethics committees has to do with about 20 years of capacity strengthening in Africa, which has taken place through Fogarty International Center, through the Wellcome Trust, through EDCTP, and through other initiatives. So you can see that there are definitely assets when it comes to research ethics committees in Africa. At the same time, there are some challenges, and those challenges have been brought out by presenting people who work in research ethics committees the prospect or their own experience of data science that they would have to review in the present and in the future. And the challenges have to do partly with individual capacity building, how to review these certain kinds of protocols, and institutional capacity building to do with governance and regulatory structures. You could say that just looking through the survey data, now is the time to try to do some more strengthening of research ethics committees in Africa at this particular moment, because it seems that it's only a minority of data science related protocols that are being reviewed now. And so now is the time to, beef up efforts to strengthen research ethics committees. That has been a struggle for the last 20 years, and now it seems we're not starting again, but we're having to redouble our efforts to strengthen the capacity of research ethics committees, which have been historically underfunded despite the efforts that have been made in the past. You could say one of the major challenges is we can talk about, having changing regulations, having governance structures, and they're all important. But I think it was said yesterday that the speed of science is faster. Governance takes time. Changing governance structures takes time. And that leaves us with a certain situation where what are we going to do in the interim when our science is going so fast and governance and changes to regulations is so slow? Well, how are we going to support research ethics committees and researchers in the interim? That's a particular kind of situation in the short term to be thought about. When it comes to the other group, the researcher group, you get out of the survey data that there's a strong sense that the lack of access to data from others is really restricting scientific progress and the progress of one's own research. And of course, researchers are going to say this, of course. So that's predictable. And what was also said that one of the reasons why data isn't shared is because sharing data costs money. Also predictable. Maybe less predictable is what came out of the survey data was the willingness to make data available depends on the perception that protections and governance is adequate, on the perception of that. So that's actually a trust issue. So you can make governance structures also, but you also need people to have confidence in them, to trust them. And so that's an open question. How do you build trust among researchers that they can share data in a secure way? Because at least through our survey data, that was a problem. That was considered a problem among our study population. Well, something else I wanted to add. I don't know how much time I have. I'm a philosopher. I can just. I'll end up anyway. We talked yesterday about, maybe we should think about public engagement, because community engagement, when your community has millions of people in it, that maybe it doesn't make sense. So you should talk about public engagement. Maybe community engagement still makes sense, but you change the communities. Research Ethics Committee, that's a community. Researchers, that's a community. And I think we have to do some engagement with them also to increase trust in the data science initiative. So just to end off, this was an exploratory study, and like any exploratory study, it shows something, it leaves something out, it points to something else. And this for us is just a first foray as an LC group into this area, and that's just the first step that we're planning to build on in the future. Thank you.
Thank you both so much. Again, please write your questions down. We'll save them till the end for everyone. Next up, as many people are very aware of the difficulties of, are just around legal clarity. How do we speak with the same language when it comes to the legal implications of data sharing? So next up, Dr. Donrick Thalder and Dr. Aliki Edgecombe, both from KZN. Thank you.
Good morning, colleagues. I will start with an example. So if I take my cell phone and I take a photo of Professor X over there, then I am the owner of the copyright in the photo, and I can make a few printouts of the photo and sell it to you, and I can sell another printout to you of the photo, and then you are the owner of that printout of the photo. Now let's make our example a little bit more complex. Say after I've taken the photo of Professor X, I've edited it to ridicule Professor X, who's usually a character of dignity and gravitas. So what is the remedy of Professor X in this case? Professor X isn't the owner of the printouts of the photo. Professor X doesn't have copyright in the photo. I'm the owner of the copyright. What's Professor X's remedy? Professor X has personality rights in his own identity, in his own image. So based on his personality rights, he can demand that I must delete the photo from my cell phone, the data. He can also demand that these printouts be destroyed. And if we do not comply with the demand, Professor X can go to court and get an interdict, or what is called in common law jurisdictions, an injunction, that I must delete the data from my cell phone and that these printouts be destroyed. So what that demonstrates is that personality rights, under certain circumstances, will supersede property rights in the printouts and will supersede intellectual property right in that photo. So the point of the example is to illustrate that a legal object, such as a photo, is multidimensional from a legal perspective. It entails property rights, IP rights, and personality rights. So the same principle applies with genomic data. To properly understand genomic data, and how to solve wicked problems with genomic data, we need to understand it in its full multidimensional legal context that will include property rights, IP rights, contract law, and personality rights. So we've published an article, well, we've written an article on this that will soon be published. We have prepared a little appetizer as a video. If you scan that QR code, you can watch the video, and we will also share the details of the article once it is published. So that is the first topic. And then if we can go to the next one, our group has also prepared a data transfer agreement template together with an explanatory memo that we hope will assist researchers a lot. Well, this first DTA template is focused on the South African research community, but after that we will also develop DTA templates for other African countries such as Kenya and Nigeria, and hopefully further as well. And their colleagues is a QR code that will take you to the DTA template. You colleagues are our clients as lawyers. You will be the users of the DTA. So your comment on that DTA would be very welcome. Thank you. Over to Aliki.
Thank you so much. Now, I don't know about you, but actually just wading through the data protection legislation across Africa was a headache, and it might have been a headache for you as well if you were doing that research, and probably even more so if you are a scientist. I'd just like to know if there's anyone that can think of something more exhilarating than working through data protection legislation of various jurisdictions, along with the policy documents, along with everything else, and trying to weave that together in a way that makes sense. And so in just doing our own research, we found that if we have that difficulty and we have an immense interest in the law, that imagine what it is like for you. It must be one of the most painful and boring experiences. And we hope that we have provided a solution that is going to take away some of that pain. And so today what we are introducing is our DSI Africa, African Data Protection Legislation website that is going to integrate all the legislation that particularly deals with health research. Okay, so you no longer are going to have to wade through massive documents, are going to have to wade through policy documents and not understand how they link together. We are going to put that together for you in a way that makes sense, and hopefully we'll be able to speak to the most important elements of research that really affect you. So we are providing an easy way to compare legislation, and we want it to be really quick for you to do and effortless. And it's going to include an integration with our guides and with our articles and webinars. But we understand that even when we produce these data guides, that sometimes they're actually really long PDFs that are as intimidating as the legislation themselves. So we are trying to streamline that and make it easier for you, that really only the pieces of information that you really need, and particularly going to be helpful for cross-border data sharing, where you're trying to compare different pieces of legislation, that is going to be the information at your fingertips rather than really cumbersome long documents. So we hoping it'll be useful both for scientists, science administrators, and lawyers alike, so it will no longer be the blind leading the blind in a lot of cases. Okay, so when we're looking at quick guidance, we're going to make it available that you can look at a particular country, okay, and you can get some more information, and that would include the data protection legislation, data guidance, any kind of relevant articles or podcasts we may have, and webinars that would help to explain that legislation on a bigger scale. But of course, often you want to compare jurisdictions, and that's been the real topic of today. How do we access all those different jurisdictions with cross-border data sharing? Well, you're going to be able to select that, see how they compare on particular issues. So when we're looking at personal information, for instance, how does South Africa's PPIA compare to Zimbabwe's Data Protection Act? right? That's a very useful comparison, and it's right in front of you. You're not having to wade through a lot of pieces of information. And if there are other bits that are also appropriate in health acts or any other regulatory documents, then those will be included as well, along with our guides and our podcasts and webinars that deal specifically with personal information. So you don't have to wade through a lot of information. Our major themes that we're focusing in on, that we've just in terms of working with some of our scientists that we have partnered with, have seen these to be the major themes: artificial intelligence, sensitive data, cross-border data sharing, obviously incredibly important, specifically in the health research context. I don't think you really care about every other context. Data, very, very interesting area. Anonymization, pseudonymization, de-identification. Of confusion around these terms. There's lots of assumptions on what these terms mean. And in fact, in the various jurisdictions, they actually mean different things. And so very important that we're able to draw those comparisons to ensure that you are actually complying, as well as giving you some guidance with your data transfer agreements, which is something that our group is working on. So hopefully this will actually be a very powerful and good tool for you to be able to use, and useful in the sense that it's going to be in plain English, so you don't have to worry that it's going to be legalese that you don't understand, and it's just going to put you to bed at night. So we're trying to make it as really as user-friendly as possible. And obviously the other strength is that it's those key pieces of legislation that you want to look at. Okay, so rather than really big pieces of legislation, we're really keying it into what you need and being able to apply it to your context. So we are aiming to have our prototype ready to launch at the beginning of next year. We've already done all of the data capturing, which was a massive task because it has to be captured and coded in order for us to be able to do the comparisons that we needed to do. And also just collecting all of that legislation was a big task, but that has all been done. And now it's just integrating it into a website. So as soon as it is ready for you to use and make use of, we will make it available to you. And then, of course, if you have any suggestions or anything you want to speak about and perhaps get us to expand on, then you're very welcome to contact us. Okay, so hopefully making law a lot less painful. All right, that's our goal. Thank you very much.
Okay, that was fun. Thank you. You figured out a way to make law fun. Wow. Thank you for doing that. I think we all needed that. Okay, I know that you will have a lot of questions. I'm sure that they will be willing to talk to you more about this tool later on, as well as at the panel later today. But next up, we're moving on to what we have already done, what has already been developed through H3 Africa and other tools that are being developed around how do we translate data sharing principles into practice. So Dr. Stephen Nabarro, a professor from the Division of Pediatric Infectious Diseases at the University of Nebraska, and the PI for camera will be up next speaking to us about what we are already accomplishing and how it's informing our next steps.
Thanks very much. Good morning, everyone. So I would need to start off by apologizing that I am not a lawyer, I'm not a philosopher, I'm just a pediatrician. Now, I am going to share my experience of training and working as a physician across 3 continents. Now, I want to start off by introducing the organization that I work with that is affiliated with DSI Africa. So the International Foundation Against Infectious Diseases in Nigeria was established to facilitate the generation of local and credible surveillance system, looking at etiologic agents of serious bacterial infections in children, opportunistic infections in the general population of Nigerian children. Now, the ultimate goal is that the data generated from these systems will be used to develop new diagnostic tests, vaccines, as well as monitor the impact of medical interventions. Now, the website address is indicated out there. Primarily what we do is to use the platform for generating this data, this surveillance system, to train and to build capacity. We started off in Nigeria. We've been able to support the federal government of Nigeria in training across several locations in Nigeria. And I would say that we've also been able to support training activities in Liberia and currently working with partners in Rwanda. We typically bring in experts from the United States at my institution in Nebraska to provide on-site training for personnel in Nigeria. And we've also had the opportunity of sending personnel from Nigeria to get training expertise in the United States, including support and facilitation by the US CDC. So much of the work that we've done in the past, I would say, has been supported by the US federal government, the Bill and Melinda Gates Foundation, and that culminated into the concept that we built into this proposal for combating antimicrobial resistance in Africa using data science, which is CAMRA. And I would say that for this particular proposal, we have 8 different partners. So we have Eagle Research Center in Rwanda, Case Western Reserve University in Ohio, United States, University of Nebraska Medical Center, J. Craig Venter Institute, IFN, University of Nebraska Lincoln, and Connecticut Children's Hospital, SGID, in Nigeria. Now, I've sort of just given that background leading on to what we are proposing to do as part of the DSI Africa Consortium. We're looking at generating data based on clinical and molecular epidemiology of antimicrobial resistance in invasive bacterial infections from Nigeria and Rwanda and children. Now, this is work that forms one of the research hubs on DSI Africa. We'll be analyzing clinical and molecular data that is related to antimicrobial resistance. And we'll be looking to translate genomics of antimicrobial resistance to sensitive and rapid diagnostics and hopefully effective therapeutics. Now, given the background of what we are proposing to do, I hope you get to understand why we feel very passionate about understanding the principles that would assist us in making the best use of the data that will generate in the course of this work. So what I'm going to try to do over the next few minutes is to make reference to what we've been talking about over the past few days and highlight some basic principles that needs to be addressed. So open science is something that we've referred to, we talked about data sharing. Now, it's very interesting that a lot of the discussion about data sharing has gone on over the past couple of days, but there's not been that much discussion on data generation. So you need to generate data before you actually have data to share. And my learned colleagues, I would say that before we engage you actively on the platform, it would be nice to ensure that before there is so much investment going into data protection, that we actually have data that can be protected. So open science is the practice of science in such a way that offers that others can collaborate and contribute where research data, lab notes, and open research processes are freely available under terms that enable reuse, redistribution, reproduction of research and its underlying data and methods. Now, this clearly has to be in the interest of the public. Those who have the data may need to seek to share data in a controlled manner with a range of users so that it is not abused. These are very critical factors. Now, you want to determine who you share the data with, how you share the data, how the data is utilized. I wanted to share this concept because I'm a physician. I deal with a lot of children And like I said, I've had the benefit of training and working in Africa, in Europe, and also the United States. The contribution from Africa to the global disease burden. Africa contributes only about 11% of the world to the world population, but contributes almost a quarter of the total global burden of disease. But research is only 2% from Africa to the global contribution. The United States, if we are looking at the number of researchers per million population, is 2,640. Europe is almost 2,000, but Africa, it's only 70 per million. Now, this is the silent elephant in the room. If there is a way of making even all these bars on this chart, I don't think we'll be gathering here having any discussion about data sharing. Now, the concern is that we have a situation where we're looking at data science, we're looking at open science platform. Would it increase scientific rigor and research efficiency? Or will it increase the risk of predatory science and research parasitism? Now, I think the concept is very clear from the graph that I shared earlier on. The risk is very high, and that is what underlies the essence of trying to address these principles. So I've tried to put this across, basically just looking at 5 pillars. We look at the projects, the people, settings, data, and output. Key considerations actually before applying any of these principles would include things like what data is there and what's going to be the value of sharing the data to the individual and also to the society. How can the data be shared in such a way that is legal? Now, it's very important, and I would say that in the course of the presentation earlier this morning, I was saying to myself, when Don made the illustration of taking the picture of someone and sharing the image, if I give you money or pay you to take a picture of you, who does that picture belong to? I'm paying you to take a picture of you, and after taking that picture, does that picture belong to me, and can I do anything with it because I've paid you to take your picture? That opens up an avenue for important discussion. Data that is being generated, where is it from? And is the data source actually fit for sharing? What's it going to be used for? Other considerations include the data generator. Do they actually, or the recipient who is going to benefit from the data, do they have the expertise? Do they have the capability to actually utilize the data meaningfully? Has the sensitivity of the data that's been generated been assessed? Now, who bears the cost of sharing the data? Governance structures need to be put in place. Who is responsible for that? And do we have arrangements in place, streamlined to ensure that all of this are possible? A number of other principles that I think are very important to address would be, yes, is all of this in the interest of the public to share the data? What are the processes in place for governance? Who will make the assessment as to whether to proceed with the project? And how do this all add up the level of restrictions that need to be put in place, again, to ensure that the data is not abused? Communication between the different groups, very critical. Ethics approval from the governance body. Do the members of the ethics committee have proper training to actually make a decision, informed decision, as to what data should be shared, how it should be shared, and issues concerning obtaining original consent from those who are contributing to the data pool is also very important. Now, people principle. So we've talked about the project principle. people principle is also very important because there are several levels of authorization within organizations that need to be put in place to ensure safety and to ensure that the use of the data is not abused, to ensure that the originator of the data is safeguarded. Because the user needs to meet any specific criteria to access data. So do they hold a security clearance? These are critical components to address. Yeah, individuals who have a poor history of managing data that is in their custody or managing data that's been shared with them. All of these are factors that need to be put into consideration in sharing data. So I've just tried again to highlight when you want to share the data, what level of restriction needs to be put on the use of the data as it gets out of reach of the primary custodian. Data. So looking again at data principle, we need to address questions around what risk can be controlled using the project, people, settings, and the principles. To direct identifiers needs to be retained, for example, as a critical part of a project. So we often talk about de-identification, removal of geolocation data. Some of these are concepts that need to be addressed depending on what data is being shared and the purpose for which it's being shared. There are specific issues associated with sensitivity of the data. How will data treatment affect utility of the data? What related data is expected to be available to user in the same environment as the shared data? Can this be controlled in such a way that you don't compromise the quality of the data and you don't put at risk the individuals who have contributed to the data pool? Output is also very important. So will the output be released publicly or made available under new data sharing agreements? Will simple rules meet the need of data custodian and users? How important is speed of response for the user? Does the output adequately protect privacy and confidentiality? Because output needs to be checked and approved before being exposed to a broader audience. All these are key principles depending on what type of data has been collected, what the data was originally meant for, and what is the purpose of sharing the data for additional analysis. What process will be followed for checking? So again, monitoring the use of the data. Who would be checking and monitoring the use of the data when it goes out of the primary control of the custodian? What extra checks need to be put in place to account for sensitivities? And will people checking outputs or using the data need training on the process? We also need to address questions post-application, and this is something that is often not done, but I think very critical. So controls minimize to ensure that you minimize the risk associated with sharing data. Unacceptable risk, which principles need to, if there are unacceptable risks, the principles need to be revisited and sort of trying to restructure the framework. Now, there are also questions around what happens to the data after it's been shared. There needs to be a plan in place to ensure that the data is destroyed after contractual agreement between the custodian and those who are utilizing the data secondarily. Can this process be audited in such a way that the secondary user doesn't go ahead to utilize the data set outside of the contractual agreement? Now, I would try and round up by saying that this concept of symbiosis, so by symbiosis we mean mutual benefit to two parties as opposed to parasitism, which tends to be exploitative. So we are hoping that the concept of data sharing should actually promote symbiosis. Now, I say that, and I would give an illustration since I'm African, that there are individuals who typically would hang around when it is time to prepare food or time to go to the farm and work, and all they are waiting for is for the food to be ready on the table, and that's when they show up. Now, we need to ask ourselves the question, those who are not seen to be actively involved in contributing to the effort of data generation, should they benefit from data sharing? So if there is going to be the use of a data set that has been generated in the past, you want to develop a new concept from the existing data set. It's only fair to identify collaborators and actively seek collaboration, particularly from those who generated the data, the primary custodian of the data. And then to explore the novel concept, you need to work collaboratively. And I would also add that when it comes to the product, there has to be a joint publication with appropriate attribution. And I cannot overemphasize that appropriate attribution. So it's not a question of the data being locally generated somewhere, and then you have an expert who has a refined and sophisticated tool for analyzing the data. The primary custodian of the data does not have the sophisticated tool in doing the analysis, but the party who comes on board to analyze the data takes advantage because they have a sophisticated tool. They take advantage and run with it. That is parasitism. Now, the way to do it would be to ensure that there is proper attribution, there is fair distribution of whatever dividend actually comes through from analyzing the data. So in conclusion, I would want to summarize by saying that open science and data sharing should improve scientific rigor and research efficiency, but only if it's appropriately implemented. We need greater community engagement, transparency, and equity from the global north and south to ensure proper implementation of open science and data sharing. Data sharing should indeed create a symbiotic and not parasitic outputs. So these are members of the lab and field team at IFEN. At the central location, we have headquartered in Abuja, the federal capital city in Nigeria. Thanks very much for your attention.
Okay, you can imagine Stephen brought up some really key thoughts that we need to just be thinking about throughout all of our work, how we do this fairly, equitably as we translate data science into practice. We're going to switch things up a little bit with our speaker order and invite Dr. Bernard Eberke, who's the Director of Research at IFANE, to talk to us about some systems that are now being developed through our research hubs to translate data science, drive it into to new practice during DSI. So welcome.
Morning, everyone. I'm just going to talk very briefly about some of our experiences on IFEN and also from trying to set up AMR surveillance systems. All right, thank you. Yeah. So so I'll just talk briefly on our experience providing support for setting up AMR, antimicrobial resistance surveillance systems in Nigeria and in West Africa. And I'll also speak briefly about some other efforts that are ongoing in the sub-region that may be relevant to data sharing in West Africa. Yeah, so like I said, I'll be speaking briefly on our support for the antimicrobial resistance surveillance system in Nigeria. That will be under the program supported by the Fleming Fund country grant. I'll also speak briefly on some initiatives that are being driven by the ECOWAS and the West Africa Health Organization. And then finally, I'll talk briefly on the initiative, the Fleming Fund Regional Grant Program, RADAR. Yeah, so by way of a brief background, the Fleming Fund Country Grant is a UK Department of Health and Social Care supported program that aims to improve capacity in developing countries for their ability to generate and report reliable AMR data. So the country grant that was provided to Nigeria, which was the first of its support for Nigeria, was implemented by a consortium that was led by DAI. IFEN, where I work, was a member of that consortium. Also in the consortium was the Institute for Human Virology. I see there's some colleagues in this room from the IHVN. Also the Livestock Management Service, Management Services, that's an animal health group. And lastly, the Liverpool School of Tropical Medicine. They were all members of the consortium. So some of us may be familiar with the Fleming Fund program as a whole, but it's good to just revisit the goals of the Fleming Fund. Essentially to improve capacity for diagnosis and surveillance of antimicrobial resistance using a One Health approach. And also to improve capacity for the regular reporting of drug resistance and sharing and the use of the AMR data locally, nationally, and globally through the WHO Global AMR Surveillance System, otherwise referred to as GLASS. So under the Fleming Fund country grant, so what exactly was done? So the country grant to Nigeria was implemented over the period 2019 to and ended pretty much at the end of 2021. So the support that was provided was to selected health facilities in the country. At the start of the country grant program, there was some scoping activities which culminated in selection of facilities to receive that support. Now, these were health facilities that were of the tertiary health facilities, which means that they had some level of specialist service provided, and they were scattered across the country. There were 9 human health facilities and 6 animal health facilities that were supported. And then there were 2 environmental health laboratories that received support from the country grant. So it's good to make that clarification that the support wasn't essentially across all the facilities, health facilities in the country. Essentially what was done was infrastructure development. So most of the laboratories, they had renovation of their physical structures. They had provision of including backup power, knowing that power supply is an important challenge in this part of the world.
They also had significant support with personnel training. So personnel training and development of protocols, standard operating protocols and lab aids. So IFEN actually was the implementation partner that was responsible for providing training support to all those selected hospitals. We also were involved in the equipment purchase. They had critical equipment supplied to those facilities, such as automated blood culture systems, like the back tech was provided for several hospitals, and supplies, laboratory supplies, although in limited quantity, was provided. So all of this was done with the aim of seeing that those facilities are able to more or less operate a functional AMR surveillance platform in their different facilities. Yeah, so I'll now dive specifically to the area of support on the Fleming Fund country grant for data sharing. I'm glad the talk given by Dr. Stephen Obaro just now, that it's important to establish that the facilities and the people involved in research or surveillance can actually generate the data in the first place. And that was the premise for the Fleming Fund country grant support. So part of the support for the Fleming Fund country grant to the country was to establish governance structures, and part of the governance structures included support for how data is shared from the surveillance or sentinel laboratories to the National Reference Laboratory. AMR data is also provided and reported from private health facilities in the country and also from other stakeholders in the country. So the Fleming Fund country grant to Nigeria provided support in drafting a data sharing agreement, which was subsequently endorsed by the country. Now, that document has been ratified now at the country level, and it's been in use right now. The Fleming Fund country grant also provided support for developing a data reporting system, which enables reporting of AMR data from the facility to from the health facility in the periphery to the National Reference Lab and the Nigeria Center for Disease Control, which is the coordinating center for AMR surveillance in the country. So the specific tool that was developed is actually an AMR information system. It was originally developed for use in Indonesia, and it was merely adapted to be used in Nigeria under the Fleming Fund country grant. It has not yet been deployed for use. It is still being tested currently. So I'll just speak very briefly now about the AMR information system, that's the AMRIS. So AMRIS operates an integrated platform for One Health data management and analysis. What it does is to integrate data from multiple sources, including the Sentinel laboratories, and also the National Reference Lab, private sector, and other healthcare service providers in the country. Now, this cuts across data that is fed into AMRIS, cuts across animal health, human health, and the environmental health. And it is been structured to be used at the national level and subnational levels. So it's also has a secure structure to allow protection of the data that is kept on that platform. And it allows for some preliminary analysis such that users can get descriptive readouts from data that they submit to that platform. So I'll just go quickly to look quickly at the site, the AMRIS site, so that we can have an idea of what it looks like. Yeah, so that's the AMRIS website. We can feel free to look it up. So essentially, it's like I said, data analysis and data repository platform for both animal health, food and the environment, as well as human health. Yeah, so it allows collation of data on antimicrobial resistance, antimicrobial consumption, and antimicrobial use. Okay, yeah, we can go on. Yeah, it's secure, it's cloud-based, and it's easily accessible by multiple users. Yeah, you can move on. Yeah, so I think we can feel free to look up the site and see all the different functionalities of AMRIS. Yeah. Yeah, so thank you. So, in the West African regional platform, there have been some efforts by the West African Health Organization as a body of the ECOWAS, the Economic Community of West African States. As at late last year, there was a meeting, the second meeting of the Technical Working Group on Antimicrobial Resistance of the ECOWAS platform. And the purpose of that meeting was to develop a One Health regional platform for information sharing. That platform was to be linked to the DHIS2 platform. So following this meeting, there's been a follow-up effort to develop a regional roadmap for antimicrobial resistance surveillance. Now, the goal of this regional roadmap is to harmonize AMR surveillance strategies within the region. I understand that document is still, it's been drafted. I'm not sure if it's been ratified by all the ministers of health in the ECOWAS member states. And then lastly, I'll just speak briefly about RADAR. So RADAR is Regional AMR Data Analysis for Advocacy, Response, and Policy. Some of us may be familiar with this program. It's a Fleming Fund regional grant. It aims to bring together various partners generating AMR, AMU, and AMC data across the globe. There have been 2 workshops I'm aware of that have been conducted on the RADAR platform, one in 2021, and then more recently, sometime I think in April of this year, there was a stakeholder workshop. And the goal of the workshop was to more or less advance a One Health framework for AMR regional data sharing and analysis, such that it could have an impact on regional and global policies. Yeah, so briefly, these are just some of the activities and initiatives that are ongoing in the sub-region, West Africa sub-region, that might be relevant for data sharing. Next steps will be to see how we can actually build on this where it's appropriate, and see where there is some positive interaction between these different platforms to move us forward. Thank you.
Thank you so much, Bernard. Last up for our scientific presentations before we get to a panel is Dr. Fred Kagwa. I haven't seen Fred. Where is Fred? Oh, there he is. Okay. So Fred is a lecturer in the Department of Computer Science at Mbarara and an investigator with the Mutzer team.
Okay, good morning. I'm Fred. I will try to be very brief. I have lots of things to talk about, but because of time, I'll give an overview of what we are doing as DMAC. Well, Mbarara University Data Science Research Hub is looking at clinical images. I think we are one of the teams that is looking at images. These images are very informative, and basically we are looking at ophthalmology as one of the research projects and gynecology. But of course, we have other pilot projects. These that are coming on. So far, we have recruited 3: pathology, dermatology, and radiology. Very, very interesting. One of the challenges that we have found that we do not have a state-of-the-art storage solution for medical research within the university. And therefore, it is very key for us to set up an open data infrastructure. And as DMAC, our main role is to see that we have an archive of these images and trying to offer clinicians a way of interacting with these and also support them in their diagnosis. 2 weeks ago, we had some interesting engagement with over 40 clinicians, with data scientists. And this, of course, also builds up the network. And of course, we are looking at having a quality process of getting the images, getting the data and processing it, and then also having it available to the different researchers. We have a data pipeline from where the sources and until when we make available the data. And some of the platforms that we have envisaged is Physionet, is an MIT-based platform, which I'm going to talk about in a few seconds. We have also developed a data portal, and of course, we're also trying to look at Elwazi as one of the platforms that we can have this data shared. But of course, after de-identification, labeling, validation, and cleaning up, and also normalization, as required by all this process, we are looking at having a very critical security and, of course, quality assurance and governance. We are all here because we know that to advance medicine, we need data, and of course, accessing data is critical for education purposes and research, implementation, but also industry. However, health data is very difficult to share because it has lots of restrictions in most of the countries, as we have already heard. So we must be very, very proactive so that we do not share data on very, very less channels. So it is important to look for open but secure channels. So I'll give a brief about Physionet. This is MIT built, maintained in the US. It was built before, not taking care of the FAIR principles, but in 2019, this was rebuilt specifically to embrace the new healthcare kind of approach, where we have cloud-based analysis, and of course, making sure that data is shareable and reusable, and of course, also reward all the different data owners or sharers, but also to bring close together the different researchers. It has over 50,000. I think last week it increased to 55,000 as of Friday, and that is really interesting. So think about Physionet as a journal that publishes data and of course software. How to get to use Physionet? You just create an account and create a project, or add in authorship details, provide the content of the data sets, And of course, how are they organized? How is it going to be utilized and reused? And of course, very critical is the access requirements, the different versions of access that are available, and it is the authors that choose. And one of these is open. There's openness. You can have it for everyone, for the public. You can also have the restricted, which requires people to log in and should have signed a data use agreement. And also we have the credentialed, which requires some critical access for sensitive data. So this requires kind of approvals. And of course, you can add in the metadata, which is very important to make your data sets findable. That's very, very critical for the NIH. And of course, the other very critical aspect is the ethics and consent details. These are also very, very important. It may require some users to first have done maybe a research ethics course before they attempt to use the data. You upload the files and then you submit for review. If the team is happy at the MIT, then yeah, your data is published. You're given a link and also a reference to your data set. And of course, if there are issues to fill in or to write about, you're given feedback to make some corrections. If you search any research concerning machine learning in critical care, you're very likely to meet the MIMIC database or a medical information mart for intensive care. This is one of their flagship database, and it's very interesting. And of course, the other one is the Brazilian labeled chest X-ray dataset. These are very key. Why are people using FusionNet to share data? And of course, they have a very good experience over 20 years. This has been in place for 20 years. And of course, they have a good state-of-art de-identification tools. And of course, I've already talked about the fine-grained access control with the different varieties. Discovery is good. If you just search for any data set in their storage, then it's easy to get. Very good reviews. Those of you who know the Roger exploration tool, and also you can have web form kind of viewers. It has a cloud integration where you can deal with Jupyter notebooks, those who are good in machine learning and etc. And of course, it has been recommended as one of the leading repositories by leading journals. That is from Springer and of course, eLife and PLOS. And of course, FusionNet, the code base is very, very open. And just Friday 28th, they actually won a prize for open data. And that is good. So it's a reason to trust that what is being done is good. As DMARC, what have we done so far? We have supported our teams in terms of REC or Research Ethics Committee, the consent form development. And for us, we also have the national level approval of research by the National Council of Science and Technology. We have developed a data transfer agreement, data user agreement. We've trained the members, the clinicians, and all the researchers with basic data science skills. And of course, emails, data request use, and etc. We've also made it possible to have a code repository. This is also something very important for the researchers. We need to see what kind of code they are writing to dig out the analysis. And of course, we have an institutional RedCap account. So far with ophthalmology, we have about over 6,000 images as of last week. And that is a bit good. And of course, we have developed a data portal, which I've already talked about it. Why are we having all these platforms for consumption of the data? We want to make it quicker in terms of findability and of course accessibility. So for that portal, we have also created a data privacy portal usage and also the terms and conditions of usage for the researchers who will want to access our data. You also have to fill in a certain request form to ease our monitoring on what exactly is being done. What we are waiting is to host that portal and also integrating with FusionNet. The challenge we are seeing there is it is easy to integrate through the cloud, but in Africa, the Google locations, I think I heard yesterday that there's one coming up in South Africa, which is good. It will ease our work. And of course, we have also procured a local storage solution because we want to build capacity locally at the university. And this will be linked up to the cloud and also ease access by the different researchers. Thank you. Welcome.
Okay, thank you all so much. As my colleagues join me up at the front for our panel discussion, a little bit of just coming back to the point of this discussion was all around how do we appropriately, legally, in an informed manner address cross-border data sharing. We've heard from teams that are developing the frameworks, that are informing through our stakeholders, that are doing incredible work developing new technologies around what we all need to be thinking about for cross-border data sharing. So please join me up front. And we'll take a couple of questions from you all. We are doing our best to stay on time because I do not want to keep anyone from tea. I know that will not make me friends. Okay, well, so I think that we're all asking some similar questions. We've been discussing this for days now around what are these current needs for taking data sharing, especially through DSI, to the next level. I would love to ask some of our from our panel members about what are the key elements that we're going to need to get data science through this consortium taken to the next level in a way that is ethical, legal, with a lot of really interesting science behind it as well. Perhaps, Donrick, I could ask you about some of the things that you're thinking about at this point around what you're going to do, especially considering you're developing these incredible platforms around this already with your website to make this accessible to people, not just other lawyers, but also the scientific community and the broader community.
Thank you. Well, I think I've highlighted the projects that we are busy with. So I don't really know what to add to that, but perhaps some of the other panel members or some of the audience would like to ask questions about it.
Sure. Yeah. If there are specific questions, especially around this platform, that hopefully is going to open up some of these questions to the more general audience, I would appreciate your questions.
There's one over there.
Judy, Mike.
Good morning. My question is not to Don, who is like probably the fastest speaker I've ever encountered, but my question to the other panelists, especially around incentives for data sharing, and specifically to the, one of the panelists who commented that you can, if you're using data sets, you have to contact the data creators and get permission and include them in your papers. And to challenge the panel to actually think about other ways of making sure that we get incentives beyond that you have to contact and get authorship, because we also know that that can also have its own unintended consequences. And for example, the MIMIC dataset presented by Kagwa has over 4,000 publications. I don't see how that would have been possible if they had to contact the original team and include them as authors. I would like to hear what the panel has in terms of difference, in terms of incentives.
Yeah.
Well, this is just an overall comment that from the ethics point of view, making an exchange with incentives for data in an environment where some research teams have a lot more resources than others, you have to be pretty careful in creating an incentive scheme, I would think, because some people will be able to give incentives and some will not.
Any other thoughts from the panel about this?
Well, incentives, I think it would be really important to have as first priority the health outcomes being achieved. If the patients are good to go and they have received feedback from the data we collected from them, and maybe treatment is good, that is already the first incentive. I think that's why the MIMIC database is actually moving very fast and getting a lot of attractions because it is open, but at the end of the day, this is intensive care and you wouldn't want someone to die. So if there is something that is real beneficial, then yeah, from treatment as an outcome, I think this is already an incentive. Yeah. Otherwise, people have done. I've seen researchers do. For example, I think Jessica has the TB adherence and etc. And then they give the participants a bottle of soda and some few biscuits, and as they're collecting data from them, I think it's high time to go beyond this and you see what is really the health outcome after the whole research process.
Thanks. I think we go beyond soda and, and tea. But maybe just to respond a little bit more to the question, because I think one of the values of PhysioNet is that the data is published just like a journal article. So the incentive is really in the hands of the researcher. So when you want to use the MIMIC data set, or hopefully some of the data sets coming out of Mudsray, it'll be available to you in a way that is already gotten through all the hurdles we talked about today. So the studies that I'm doing that Fred mentioned, in trying to share my data, it takes like a year, to go through all of the hurdles. And these are important issues, as we've highlighted today. We want to make sure it's safe. We want to make sure people are protected. But the bureaucracy of getting through all of those layers is almost, I think it's harmful, in a way, because we're not able to answer those questions that so many of us want to ask. And so what Fred was presenting with PhysioNet, I think, is a really interesting idea to think about in the African context. It's not being used here currently. It's been in the US, it's being used in Canada, I think maybe a few other places around the world, but it needs to be adapted for this context. And I'm really excited to think through all of the issues that were brought up today about it. But the incentive, going back to your original question, is really where it should be, in the hands of the researcher. And these kind of systems create the opportunity to do that in a much more expedient way and a much more protected way, and one that also promotes academic achievement, because the data gets cited just like any kind of journal gets cited. And I think that really just enhances the collaboration and encourages us to work together so much more efficiently and effectively.
Thanks very much. Lots of questions, great. I'm scanning right over here for our next question.
Thanks. Thank you for a very clear and exciting talk about the data corridor in Africa. The question that I have is whether you're familiar with the code of conduct that's been developed by the South African Academy of Sciences in terms of the South African Population Protection of Personal Information Act, and whether the protocol that you have in mind is similar to that code of conduct, and whether there's any similarities. Thank you.
I think would you want to go first, or must I go? You must go first.
Thank you for the question. Yes, the Academy of Science of South Africa decided to embark on a project to develop a code of conduct for research about 2 years ago. Initially, they intended to have it finished within, 3 or 4 months. It's now about 2 years. They've sent out numerous drafts to stakeholders. We were involved in that, so we've made a number of submissions to them. Their first public draft was published, I think, about a month ago. We've made comprehensive submissions, I think running into about 20,000 words on the draft code of conduct. So I think the draft is still far from ready to be submitted to the information regulator. It will not pass in its current form. However, we've had very constructive engagement with the ASAF group working on the draft code of conduct. And we've actually agreed with them that they will send us informally their amended versions as they start amending it. And we will then be in informal contact with them and hopefully assist them and help them to improve the draft code to such a level that it can actually be submitted to the information regulator. So that's just regarding the general progress. The link with the data corridor, well, there's of course no explicit link to that idea or to a protocol to the Malabo Convention that says that is not necessary. It's not necessary to have that in your code. But in principle, the code can be completely aligned with our vision of an African data corridor. And we've also made specific recommendations to ASAF to build in certain aspects in the code. For example, creating clarity regarding what is the legal pathway for open science, a legal pathway to share your data in a secure environment, but with access to groups internationally, all of those things, to make it clear to the South African research community that those are all possibilities in terms of POPIA by making clear provision for it in the code. So hopefully, in a step-by-step incremental fashion, we can get to a situation where there's greater legal clarity for all researchers involved. I hope that answered your question. Thank you.
Okay. First, a couple rows down here, and then Katrine.
Yes, my question is to Don. Looking at the way you said you would examine the laws on the African continent, and give a comparison of the different laws of nations, I want to ask, how would you do that without integrating opinions and interpretations of the law, which at national levels, the courts and the individual jurisdictions may interpret otherwise? Meanwhile, this would have become a resource that probably would have guided thoughts. It's a wonderful idea to do, but I'm just wondering how you would be able to achieve that without some inflections of your thoughts on the comparisons of these national laws. Thank you.
I'm very happy to speak to that. Thank you for that question. Yeah. The purpose is to obviously first do the comparison between those legislations, so to be able to see what that one piece of legislation says about anonymization and another. But part of that will actually be links to the guides that we have developed, because we have spent a lot of time doing those comparisons and writing articles, bringing together the information in a user-friendly way. So it will actually be integrated. And so the purpose of actually building this tool is to make that information far more accessible and pointed. So it's not going to take away from the very important need of obviously having commentary, because we understand that people looking at it wouldn't actually necessarily know what it means. But the other issue, and a lot of the websites that I actually had a look at, only actually had commentary. So they had one, jurisdiction compared to the other, but it was all paraphrased. Now there's an issue in that, because obviously that you are now then seeing it through the eyes of a person's interpretation that may or may not be correct. And obviously we know that things develop all the time. So even the guides that we are producing in PDF form, by the end of the year, will probably be outdated, because there would have been case law perhaps or extra guidance. And so the point of actually putting it into a website means that we can update it. It's dynamic rather than static, which obviously feeds into that, and is going to provide more pointed help. It is not going to take the place of legal advice, of your ethics committee boards, of actual research. So it's going to be a first step rather than the end goal. And I think what is lacking is really actually even the first step, is that just to access all the different legislation is very difficult. And to bring all of that together has been actually a process that has taken us the better part of the year. And so actually having it in one place is important for people, and being able to do those quick little cross analysis with being able to look at guides and having more information. So it's providing the framework, not necessarily all the detail you'll need, but at least you have the framework and you have access to the more detailed information on those particular topics. So I hope that that answers it and answers your concerns. Thank you.
If I may add to that, if I understand our colleague from Nigeria's question, I think the concern might also be that, of course, in local court judgments, those judgments, what you refer to as court opinions, they add texture to what one finds in a statute, if I understand you correctly. And that's very important. So as lawyers, we also try to find all of that case law so that we can view the relevant legislation as interpreted by the local courts. So we really attempt to do that in that depth. Each country, of course, is complex with its own court structure and so on. So I would like to invite you, as our Nigerian legal colleagues, to act as critical readers on what we produce. I think not only because we've got a lot of confidence in the work that we do to involve another group, but I think it will really add value. So I'm very serious, and we will appreciate it if you can act as critical readers to what we produce. Thank you.
Okay, Katrine. And then next to you after that.
Can you hear? I apologize. I wanted to ask the panel, so our team over the last month got, 4 of our investigators got emailed by scientists asking for data sharing. And when we did a little digging, these were not academics, they were industry. And we felt uncomfortable sharing any data with them, obviously, and we kind of just said, oh, the consortium's trying to figure this out in terms of the ethics of it, and we can't do it. But I was wondering, this brought into question for me, does the intent of the person with whom the data are being shared matter in terms of access, pricing, tiered approach? Because the industry is going to be able to afford things that others can't. They have a different motive for doing some of the work they're doing. So I was wondering what members of the panel thought about this type of issue with data sharing.
I don't know why you felt uncomfortable, but sharing is sharing. If you decide in principle that you support open science, then you support open science, not only for people that you like or ideologically agree with or that are other academics, but you share. That would be my opinion. And also, yes. I'm very...
I didn't like that they didn't approach us directly about what they wanted the data for. So that made me uncomfortable in terms of protecting the study subjects and what they had signed up for.
Oh, absolutely. I think it all depends on what you state in your consent form. So your consent form may, for example, state that the data that is generated will only be available to certain groups and not to others. So just for academic research and not for industry research. But let's think of this at another level. Look, so first, I think the observation was just from the perspective of open science and as a matter of principle. But I think one should also look at what is the contractual expectation by the NIH in terms of data sharing, and then simply ensure that you comply with that contractual obligation.
Okay, next, yeah.
Yes, thank you very much. I just want to follow up on something that was mentioned. I don't think I got it right, but could you clarify whether there was a Nigerian data sharing agreement that has been drafted, a national agreement? There was a presenter who mentioned, and where is it available and the content?
So my presentation and the information I've provided is actually with respect to antimicrobial resistance surveillance in Nigeria. And specifically for that purpose, there's been a data sharing agreement that has been drafted and I would say ratified by the relevant bodies in Nigeria. That document is supposed to facilitate transfer of AMR data from the different stakeholders in the country to the National AMR Surveillance Coordinating Center. So that's the purpose of that. And probably to give some context, there was quite a bit of reluctance from some of the Sentinel hospitals. They were reluctant to release their data because they wanted to be sure that they will be acknowledged when that data is used at the national level. So, I mean, even before you go into cross-border or cross-country challenges with sharing data, even within the country, there were some hesitation about releasing data. Thank you.
Sure. Yeah.
Yes, I wanted to comment on what Catherine talked about, the industry. We actually have a challenge. We have one of our partners who is supposed to support us in data collection for the cervical cancer images. And where they have this very interesting terms of use agreement where they, because when we collect data using their tool, They offer tools to help us collect data, but the data is uploaded to their cloud and then we pick it from their cloud. Very interesting. So their terms of use agreement says that they can use our data for development of algorithms to improve their industry-related tools. But of course, this is scary, and of course, it needs lots of discussions. I think one of our colleagues also from Cameroon talked about that. They have another organization, industry, that has experience in collecting some data, very good tools, but it's almost the same nature. So there are issues with industry, and it really needs discussion.
To vulnerability of a lot of countries on the continent of Africa. Now, if only African country government will invest in generating data, then we'll be in a better position to claim ownership and decide who we share that data with. I think I have a problem with situations where you have foreign countries providing significant, substantial financial support in setting up surveillance in African countries, and then we turn around in Africa and want to claim ownership of the data. So in as much as we want to leverage the opportunities available, I think we will be in a better position if African government will invest more in generating data in Africa, and then we'll be in a better position to claim ownership and decide who we share that data with.
Yeah, in fact, I just want to support what Dr. Stephen Obaro just said in his talk, that we need to work collaboratively. Some of the training programs we have in the DSI consortium are actually based on developing methods. So they don't generate data, but you need data. So for example, we have got 4 postdocs in our hub who immediately need data. So we had to think of alternative ways on how to do it from University of KwaZulu-Natal. So what did we do? We had to approach research institutions like African Health Research Institute and CAPRISA, and we had to talk to them so that we build trust and confidence so that we work collaboratively with them. So actually what Dr. Stephen Obaro said is important, that we in Africa, we create this culture of working collaboratively together rather than in silos. I think that is very important. Thank you.
Okay, time for one more question.
I think it's important to have a level of discomfort when one is sharing data with third parties. Ethically, this is a requirement. I mean, we obtain data from data donors. They trust us to use their data ethically. And I think it's really important that upfront one is clear about who one is sharing data with and the intent of those third parties as well. The second issue relates to the continent of Africa and the importance of sovereignty. And I think it's really important that the perspectives of different countries, the rules, the laws of governments are taken into account. And that, we've had this problem in terms of ethics committees on the continent already. So, there's a federal-wide assurance from the USA, and some countries in Africa do not want to be accredited by the USA. So issues around sovereignty are very sensitive and important to take into account in Africa. And the third issue revolves around the issue of primary sources of data on the continent. We have Francophone countries and Lusophone countries, and where legislation is written in other languages, we need to be particularly careful about how that law is interpreted, translated, who does it, etc. Thank you, Brad.
So maybe just a last question from my side. I was just thinking, how do we then encourage public-private partnerships if there's going to be reluctance in terms of data sharing? Because we know from the industry side as well, there is intention. So if you look at efforts such as AI for social good, there is an interest to really use technologies to help with some of the complex challenges that are being faced on the continent. So what do we need to put in place to ensure that there is that sharing of data and other resources between the public and the private sector, and not just to academia, but we also know we also have a large contingency of researchers that are also sitting in with industry partners. So how do we facilitate better collaboration between the private sector and the public sector?
I don't have a direct answer to that very important question of facilitating private and public partnership. I think that's definitely something that we can all give some more intense thought. I also agree with Kaimantri's sentiments about sharing and that one must do it in a responsible fashion. But then also we must remember, at least in the South African context, there is several government policies in place already that aims at bridging the gap between academia and industry. And not only policies, in fact, there is actually a statute regarding intellectual property that must be protected. Well, intellectual property coming from publicly funded research, which is mostly in academia, but sometimes in the private sector, but mostly at universities. It must be protected, and if there's commercial value in such IP, it must be commercialized. And there, the Act makes provision for collaboration between academia and the private sector, both within South Africa, licenses abroad, all of that. So there's already a very strong policy imperative and actually a legal, statutory imperative towards that. So in other words, when researchers engage in health research, it's not only about finding health solutions. At least from a South African policy and legal perspective, it's also about how will those health solutions contribute to building the economy in South Africa? How will it contribute to building a private sector economy in South Africa? So that is a policy imperative that must be considered from the very onset. So when you draft your consent form, when you plan your research, you must plan for this to happen because it's a policy and a legal imperative. Else you will be in massive trouble at the end if there's an issue with the commercialization of your product because of how you structured your informed consent at the beginning. So I think that is something that must be kept in mind from the very planning stages. Thank you.
Great. Well, I invite you all to thank our incredible panel for starting us out on an incredible first session. So thank you all so much.
Thank you.
With that, tea break.
Thank you.
Yes, thank you.
One, two, 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 testing, one, two, one, two, one, two. One, two, one, two, one, two, one, two. Go.
Okay. Well, hello everyone. Thanks for joining us for our workshop on funding equitable data science. My name is Ekin, and this is my colleague Grace, and we both work for the Wellcome Trust, which is a research funder based in London in the UK. So before jumping into the details of today's discussion, we'd like to give you a little bit of a background about ourselves and about our organization. So, well, by training, I'm a geneticist. I spent quite a lot of time looking into how gene expression regulates organismal aging before becoming a research funder a few years ago. Just in general, I'm really passionate about I'm really passionate about making a positive impact on health globally through research and technology.
I'm going to keep forgetting to do that. So my name's Grace. I am the program advisor for our team, which means that I look after communications, learning and influence type work. And that's why I'm here today, because we're really keen to learn from you and learn together. My background is in history, so I'm not a data person, not a technologist. I always feel like I should caveat that at the beginning. But I'm really excited to hopefully help facilitate a conversation today. Cool. So we'll start with just a bit of background about Wellcome. I'm going to keep forgetting to do that. So our goal as a funder is to improve health by funding research, building global partnerships, and running advocacy campaigns. We're a global charitable foundation, and as Ekin said, we're based in London. And we really want to try and work with people and organizations that are using science to solve the world's most urgent health challenges. And you may be, many of you are probably familiar with Wellcome, and historically we've funded relatively broadly often, and sometimes quite reactively. And one of the things that we're trying to do now, under a new strategy that we developed, is to focus our attention across some really crucial and urgent health challenges. So I'll hand over to Ekin to talk you through what those are.
So the first health challenge that Wellcome is focusing currently is mental health. And this is because we know that depression, anxiety, and psychosis hold millions of people back every day. However, we still know very little about why these conditions develop and what are the best ways of resolving them. So our mission here is to create a world where no one is held back by mental health related conditions. And infectious diseases is the second health challenge area that we are focusing on. And I guess probably no one in this room needs any further convincing that the risk of new infectious diseases emerging is rising every day. So we want to fund research to understand the sources and drivers of infectious diseases. And we'd like to support the development of accessible products and tools. And again, the goal is to create a world in which there is a reduced risk and impact of escalating infectious diseases. And finally, our third health challenge area is climate and health, because we recognize that climate crisis is a health crisis, and we want to put health at the heart of the climate action. So on the top of these three health challenge areas that we are focusing on, I guess quite a few of you will be familiar that Wellcome has a big track record in funding discovery research. And we want to continue to transform our understanding of life, health, and well-being through supporting curiosity-driven research across a different number of topics and career stages.
But now onto our team. So we are part of the Data for Science and Health team at Wellcome, and our goal is around funding trustworthy data science to help solve the urgent health challenges that Ekin just mentioned. And we've also got our the head of our team, Tarek, here. Give everyone a wave, Tarek, who's the head of Data for Science and Health at Wellcome as well. And our team looks at this through kind of three different areas. So one area is just around funding a portfolio of technology that really helps achieve Wellcome's aims in those three areas that we just talked about. The second is recognizing that the environment is crucial And I mean, the conversations this morning have really highlighted that as well. So the second is around influencing the data governance standards and institutional policies within which data for science and health happens. And the third one is around prioritizing the needs of communities developing, using, and affected by new tools and new ways of using data. So I was struck by a comment earlier about, how we define communities and what we mean. So here we mean, researchers, data scientists, etc. But we also mean, members of the public who maybe are represented in data sets or will be affected by new tools or new kinds of research using data. Okay, so to go on to the plan for today, I think most importantly, our goal here is really just to facilitate a conversation, learn from you, listen to your views, experiences, and expertise, and see how we can kind of use what we hear to influence the way that we work as a team. But also, hopefully, we want to kind of facilitate conversation between yourselves as well. So we're looking at covering 3 aspects of equity in data for science and health. So the first one is about mechanisms, the funding mechanisms. So what equitable mechanisms for funding data science could we explore? Is question 1. The second one is about the data itself, the raw materials. So we want to talk about gaps or limitations that you've seen in the data sources you work with that could prevent equitable outcomes, and perhaps think about what the role of funders might be to help improve those areas. And finally, we want to talk about how we can support engagement with the communities where the data comes from. So this is people, the people represented in the data. And yeah, as I said, we want to make this a conversation where we can think and learn collectively. So we'll have 25 minutes to talk about each of the 3 questions. We'll share a couple of examples of things that we're trying, projects we're working on, with full recognition that they're not the solution, but they're just a couple of prompts and thoughts we've had. We'll then give you some time to discuss together. So we'll ask you to kind of get into groups of 3 or 4, something like that, and have a discussion around the question of the topic. And we'd also be really keen, if you don't mind taking notes, to share with us back. So if there's things that we don't capture in the next section, which is the group discussion, we'll still make sure that we kind of hear your, capture your thoughts and feedback in the synthesis afterwards. And what we're hoping to do is take what we learn, back to our team, but also we'd quite like to try and publish a blog or an outline article or something to share our learning more widely with other funders and with other researchers, and just kind of share the learning in the open. And at the end, we'll explain, like, if you'd like to have your name on that blog as a contributor, we'll let you know how. So cool. We'll jump to the first question, give you a couple of prompts, and get ready to start moving into your groups once Ekin is finished. Off you go.
Okay, so the first question that I would like to focus on altogether is what equitable mechanisms for funding data science could we explore? So at Wellcome, we have a few different routes to funding research, and one of them is having open calls, which can have like specific themes or can be aimed at specific career stages. But we also make some standalone discretionary awards, which probably require a little bit of us working more closely with potential applicants. However, we want to be a better global funder, and Data for Science and Health team at Wellcome is a relatively new team. And we want to try different approaches that can be better suited to priorities in different regions, including the African continent. We have a few examples of different funding mechanisms and approaches that we've been trying recently. And
I'll talk about the first one. So this is a piece of work that has sort of just kicked off, actually, and we are funding some regional hubs to train data scientists to work at the intersection of climate and health. There's going to be one hub in India and one hub based on the African continent. The exact locations are being worked on. And through these hubs, we're hoping to train 100, I say we, the partners that are going to run them. We're hoping to fund the training of 100 to 200 data professionals that have those interdisciplinary skills to work at the intersections of climate and health. And I think what's really interesting about this project specifically as well is that as part of that, the trainees will have a funded fellowship or placement in a social impact or a public sector organisation in their country or region, etc., to try and also make sure that that learning is shared across to that different sector. And also will be, or the team will be making sure that the resources that are used for this programme are open source, trying to help expand the reach, scale and impact of it.
Okay, so the second example that I would like to share with you is the Mental Health Data Prize that we launched earlier this year. And I have to say, this is the one that I am actually quite closely attached to because I led on it. So this is a challenge-led funding mechanism that aims to bring groups of multidisciplinary teams from the UK and South Africa. And the overall goal here is to use existing mental health related data sets from the UK and South Africa to understand which aspects of mental health interventions are effective for young people with anxiety and depression. So when we were kind of at the preparation stage of this Mental Health Data Prize, we had really amazing engagement from the research community in South Africa. But unfortunately, when we launched it, we didn't get as many applications as we would have liked to. And we did a bit of a follow-up to understand what might be the reason of that and what could have been the potential barriers, which gave us some interesting indications. For example, the kind of limitation of resources could have been a problem. And also as part of our eligibility criteria, we made it mandatory to have a South Africa-based lead to work on data resources coming from South Africa. But it turned out that actually most of the potential applicants could have preferred having the flexibility of having a co-lead from elsewhere. And also just to say that we are thinking of rerunning this Mental Health Data Prize only in South Africa. And we would like to really tailor it much better to the needs and the priorities of the community here. So just to say, whatever discussions come out of, whatever outcomes we get from today's discussions actually could help us to tailor that. And also, if anyone would like to talk to us a little bit more on the Mental Health Data Prize, we'll be around over the next 2 days, so come and talk to us. Okay, so now it's time for our discussion. And if you could group yourselves in perhaps 3 or 4 people, like if you could just perhaps grab whoever is sitting just near you and have a bit of a discussion on what equitable mechanisms for funding data science could we explore. And I would really like to kind of invite you to think about what you have seen in your experience that has worked well or that hasn't worked well, and which kind of tangible actions you would really recommend to funders to take that would be better suited to your priorities. And, you know, like there's us, and I think there are NIH colleagues in the room as well. So, so this is like a really kind of a good opportunity to just let us know about your experience so far.
Any questions? I tell you what, if you get into your groups, if you've got any questions, give us a wave and we'll come over.
Are people grouping up? Are people grouping up? I think they are.
Always takes a little bit of time.
Yeah.
Hello? Oh, yeah. 2 minute warning. 2 minute warning. You got a question? Can you get 4? 3 minutes then.
Clarification.
Yeah. Sorry. Yep. Sorry. The network, yes. I don't exactly know on the top of my head, but I can get back to you. Like, I'll give you my email.
And then another question. So, like for the mental health rights,
Yeah.
I was just wondering. So you've limited it to Africa,
Yeah.
among all the other African
African
countries.
Hello. I'm going to wrap us up now because we want to hear from and have a bit of a broader discussion. So if you finish making your final points, and then we'll have a group discussion and hear back from the different groups. I mean, it looks like there's a lot to say. Okay, which? Oh. Go on.
Okay, sorry, I got distracted chatting to people, so the time is up. I hope everyone had useful brainstorming with their in their groups. And what we're going to do now is report back the outcome of the discussions from a number of groups over the next 8 minutes. Is that right? And if we haven't captured your thoughts, please make sure to keep your piece of paper so that we can collect that at the end, right? So who would like to start? If not, I'm gonna say, oh, there you go. There we go.
Thank you. I think the first question, and maybe I don't know if the other groups were struggling, was how do you guys define the word equitable? Because I could define it as differently, but I think she mentioned it's about, how the community of the data science and then who are engaged in the research. But if you could just give a broad definition of how you define yourself as equitable mechanisms. And then I think the example that you gave that you're creating 2 research hubs, I think one in Africa and one in India. Both of the populations are the same, right? Because India is about 1.2 billion and Africa is about 1.2 billion. But I think you need to realize the fact that maybe somebody in Southern Africa is not similar to somebody in Western or North Africa. So creating different research hubs, something similar to how the UN works, right? There's a Western area, there's a Eastern area, and then there's a Southern area. Creating different hubs will probably even bring in the diversity of the research that you're kind of doing rather than having that one Africa hub. Because I think as much as we all say we are Africans, we hate to say that I'm going to Africa, right? I would want to say that I'm going to South Africa, not going to Africa. So I think that's something that we need to probably start removing the notion that we're using Africa as the word, but now have specific regions out of that. And then I think the other mechanism which she also mentioned was you also have this private nonprofit and then your academic institution collaborations. I think this will also enhance and reach and get a lot of data that comes out, because we know when academics don't get their funding and then industry has a lot of money or the nonprofits have the money, there is money that will allow to generate data. So having that engagement and collaboration, I think would help to boost and get more data.
Yeah, thank you. That's a really, thank you for those reflections. Just one on your point around the accelerator hub, the hubs for climate and health training. I totally agree. I think we're just starting off with 2. We've never run a program like that before. So we're sort of thinking about them as like pilots, but I think I totally agree that the point is well made that it needs to be potentially more specific about exactly where and also tailored to those kind of that local regional context. So we're actually funding partners to run those who already have like really good networks in the like locations that we're going to set up the hub, so that hopefully like the partners through that network will already kind of have an understanding of the context that we won't, and therefore be able to reach out to the right people. Yeah, thank you.
Okay, okay, thank you. So I have 4 ideas from our group. They're here with me. The first one is that you could consider implementing data hackathons for students. You have a set of data, you invite students you make use of it, sort of.
Yeah.
And then that could be able to solve the problem of equitability. Then the second one is to perhaps implement a research funding or fellowship to encourage young postgraduates and young researchers cross-disciplinary collaboration. So I'm a lawyer, I've been hearing a lot of data, statisticians, and of course, those who work in the health sector. So if I'm able to be taken to those particular groups, It will help me better come up with interventions in law. Third one is ideation, which is just funding to encourage ideas, big ideas from young university students, or just give them an opportunity to discuss. And then the last one, from a legal point of view, was to perhaps look at moot courts to test, to explore the legal landscape in generating, using, and sharing data. So if you're able to come up with those problems you're talking about and put them in form of a moot court, for law schools, that is, they're able to, of course, generate solutions which might be interesting for scientists to use. Thank you.
That was brilliant, thank you. Really appreciate also the ideas of how to bring these disciplines together. That's really crucial. Yeah.
Hi, thank you. We have a couple of points. I'll talk about one and then I'll pass on to maybe someone else to talk about the others. The first one is, so I know like the Wellcome Trust is a UK funder, so there's often the kind of insisting to have a collaborator from the UK, even if it's not mandated. So there's the worry that applications that do not have these collaborators from the UK or Europe or the US are less competitive. And I think that there should be calls that are strictly mandated for African groups, with the leads, not co-PIs, but the very leads and administration being in Africa. Because otherwise, even if it's not conscious, I think when reviewers look at applications, there is the bias that maybe these applications are less competitive. And maybe, do you want to talk about the issue of the young?
Do you want to respond to that?
Oh, okay. One of the other things we talked about was catch them young, kind of thing, that there is the observation that from the global north, the gap between those who actually get the grants and those who do is very wide. And one of the reasons is that in the global north, people are trained early in research methods and research methodology, in writing grants, in the skill of grantsmanship. Not only that, there are mentors that you see, but in the global south, the idea of research comes much later. Usually, or mostly, is post-PhD. So you start the curve just after that, which is a little late, which results in the fact that before you get the grasp of it, it's a little bit late in the day. So the suggestion is that there should be a funding or a move to ensure that the art of ideation, grants writing, proposal writing, identifying gaps and all are done very, very early. So curriculum is another thing apart from training, that we should actually do it early. The other reason is that if I take Nigeria, for instance, over 56% of the population are young people. But if you look at the cream of the scientists, the grant writers, those who are forging the gaps, identifying it and writing the proposals, are mostly between the age of 55 to 65, if not older. And if we look at the majority of the problem and how it affects the majority of the population, you would agree with me that it cannot be very representative. So if only for that, it's advised that we do that route of catching them young. I think the final thing was about administrative, that our research management offices, our research managers should also be taken along in this process because of, I don't want to use a better word to use, ignorance. Please pardon me. I'm not meaning it negatively, it's just that I can't think of another word. They are not as helpful as they should be. But if they are trained and they understand, you'll be able to take them out of the bureaucratic process of bursary of accounts of the university to understand that funding of research is very different from the accounting process of the university, even though it is under that umbrella, that the idea of a funder funding a project is different from the idea of money coming for government for water bills and electricity bills. So the attention, the response, the paperwork should be different. So there is a need to carry them along too in training and in opening up of minds. Thank you.
That was brilliant. Thank you. We could carry on talking about this question, I think, for ages, but we are out of our time for this question. So what I might do is move us on to the next one. And yeah, please do kind of keep any notes you've made as in your teams and give those to us at the end, or come and chat to us later as well if you'd rather have a conversation face to face. Bear with me one sec while I figure out what I've done to this. Yeah, I'll use your laptop after this. Yeah. Should we trade?
Okay, yeah, I just echo what Grace has said. These are absolutely great kind of pointers for us about what can be done differently and better. So thank you for your ideas. Okay, so now we somehow looked at the mechanisms for funding, and we'd like to switch gears a little bit and kind of look at the starting raw material. So so in other words, data sources, and what gaps or limitations are there in the data sources that you work with that may prevent equitable outcomes? We recognize that the variety and diversity of data used in health research is important to ensure that we get equitable outcomes, and sometimes it may be quite tricky to find this kind of ideal rich raw material. In often cases, data might be biased towards certain geographical locations or ethnic backgrounds or any other socio-demographic factors. And in fact, at Wellcome, we have a few initiatives that aims to address this issue.
Okay, so I'm going to talk through one example, which is a piece of work that the team that like an old team of mine has been working on. And if you'll excuse me, it's a UK-based example. And so I just want to be clear that like my kind of goal of sharing this is not to say that this same approach will be kind of relevant in any of your settings, but more just as an example of something, a kind of a project or a way of working that we've tried. So during the pandemic, it became very clear that people from Black and South Asian groups in the UK were experiencing much worse outcomes from COVID. And at the same time, a sort of an ongoing debate that people were aware of resurfaced, which was that there's also big gaps in the health data and data sets in terms of ethnicity recording. So even to try and figure out exactly how people were affected by the pandemic was hard. And so government and the health service started saying, well, we need to collect more data or fix these problems by, just basically going out and filling the gaps. But the team that I was working in felt that to do that, you need to start by understanding these people's experiences, perspectives, and kind of try and really dive into why there were gaps in the data in the first place. What's the problem? Really kind of get into the problem before just kind of forging ahead and trying to get more data. And so my team ran some qualitative research to understand people's experiences. And they also they did that through working with a small agency who also had trained a network of community researchers who spoke to kind of their networks, etc. So it was quite an interesting model, I suppose, of research. And so it started off with that. There's also been some quantitative research. And off the back of that, using the findings, the team's trying to develop some resources for healthcare professionals to try and have better conversations about data, try and explain how it might be used and why recording ethnicity properly is so important. And also to try and influence government and the health services approach to sort of addressing this issue. And finally, we're also in a separate related piece of work, coming at it from the other angle, which is working with the National Stats Agency to try and develop some methods for analysts that are working with this health data to deal with those gaps, so that the analyses that they produce don't kind of neglect the needs or issues affecting these groups. So that's the first one. And then one other example to mention is we are funding or contributing to the Lacuna Fund, and they are running a call for new and improved data sets from low and middle income countries that are granular enough, large enough for machine learning. So we're calling them kind of like machine learning ready data sets. And the focus of those is on, there's kind of twofold. One is just getting a better understanding of climate harms on health and livelihoods. And the second one is much more on the kind of planning and response side to inform policy reaction. And it closed in the summer, so I haven't got any examples to share yet. But we're really excited to see what projects kind of come through that fund too.
Okay, so then this is almost time for our second discussion, 10 minutes of discussion. So I'd like to invite you to think about what gaps, limitations, or problems have you encountered in data sets that you have seen in your work. And in a way, building on the examples that we just shared with you, what do you think funders can help to address these issues? And you could think along the lines of data linkage or enrichment or generation of new data. And yes, we have 10 minutes and we'll be reporting back the discussion outcomes in a bit.
Can you hear me? Atkins, the worst again. No, I'm joking. Great. Oh, you're leading this.
Okay, sorry, I think we've gone over time again, but it's just really nice discussion, so I got caught up in it, sorry. Okay, so it's time for our the reporting back from our group discussions, and perhaps over the next 5 minutes, we have to, sorry, but we'll be collecting your ideas on the piece of paper, so that's all good. So who would like to start?
Yeah, I was going to
Yeah, it's true, so you can be the next one.
We are biased because you're with us.
Didn't you go before?
You were with us.
I know, no, I know. Didn't you go last time? No.
Yeah, so we deliberated on some key things. I'll mention some, and my colleagues here will do the remaining. So one of the challenges one of the things that we thought of is the lack of a technical know-how in developing data systems in resource limited settings. We have very few developers. Now we have many data analysts coming up, but the developers to develop in-house applications to able to collect local data sets are very limited. So that's one of the things that we face right now. Another thing that we considered is linking population-based data to health facility data. We do not have a common ID scheme, for instance, to be able to link directly individuals' data sets in the facility to the population-based surveys or surveillance systems. There are studies or projects that considered that using a biometric system, but that was on a very limited scale. We would recommend that it's implemented on a larger scale so that we have data readily available in real time. Yeah, so I think I'll touch on these two, and my other team members would.
Okay, something else that we talked about was your localization of the data that you're collecting. Sometimes when you collect data, you're collecting it at big institutions and facilities, but the communities you seek to serve are very rural. And for them to travel like 40 kilometers or 50 kilometers to access that and have the data captured sometimes is unfeasible. An example of this is like if you look at the the birth rates in Uganda, there's a high mortality rate for women who are delivering babies there because they're coming from rural areas, and to try and get to a hospital, it's kind of unfeasible, especially given the transport situations there. So having some kind of data systems where people know that, okay, this village is going to have such and such births, and could we have a midwife over there and provide some services there? Right, so you get the services going to the people. So I think your localization of where you collect your data is quite important.
Thank you. So I'm the non-technical one of the group, so I'm going to use some fancy words which I learned today. We spoke about data harmonization, which I think can be further explained in discussion on the side, but basically to find a framework that can be used between different sources of data, a harmonizing framework for definitions. Then the second part was standardization of the tools by also standardizing the definition of key indicators. So I think those are the two things I got from it. Thanks.
Thank you so much. All really very useful ideas. And it's over to you now. And I think this is going to be the last one actually, because we're running out of time.
I'll be quick.
No pressure.
Yeah, I just wanted, I think for us, our discussion was some of the instruments and the tools that we use to generate data and whether they adequately represent all population groups. And in many instances, the funding dictates how expansive your population groups are. And so we talked about two examples. One is in the work that I do, I work on HIV globally. And we now know that 65% of new infections globally, not in Africa, is in key populations and their partners. Now, in many instances, these are people that are on the margins of society because of discriminatory laws, prohibitive policies. And so it's difficult to reach them unless you have a deliberate and clear approach as to how to reach them. And we know what to do. It's through the networks and all that. So in safe places where they can participate. But then it's also the investments in these populations and who's funding. And in many instances, if governments themselves are funding some of these studies, they don't want to put that additional investments to make sure that we reach them because the sample sizes are expanded and it's more expensive. So then we continue to work with very limited data that's unreliable, and that is a very costly venture, because if you don't know who you're dealing with, then you can't be predictive about the things that you need to do to get the results that you need. We also talked about just how systems themselves are prohibitive. And so if the populations you want to reach don't have the trust in the health system, and I gave an example of some of the ongoings in New York that I know are going on even around HIV, not COVID research, and how populations, marginalized populations of color have been so resistant to being part of the response that even when you do studies, it's not easy for the study groups to recruit these populations because they're not coming forward because they don't have the confidence that the study is intended for them and in good use of the results by them. So what has happened to that, and I have friends that are working in New York State where the research groups actually put in additional investments just for creating that awareness so that the populations that are accrued are more inclusive of the populations that are most impacted by the problem.
Great. Thank you so much. And actually, that last point somehow transitions us really nicely into our next discussion point, which is the only thing that stands between you and your lunch. It's great minds.
So as Ekin said, I think those discussions, have set us up well, because now we'll turn to perhaps the most important consideration, which is the people behind the data, or the people behind the numbers. And, data about our health can feel very sensitive, very personal, but also, I think this group recognizes it can have huge value for improving health and well-being. But we just believe it's really important to kind of engage with, when I say communities, I probably really mean people, or people represented in the data. So again, to give a couple of examples. So again, if you'll bear with me, this is a UK example that my previous team worked on. The UK has a kind of huge health data resource collected from kind of cradle to grave, with good electronic health record coverage, and access to data for research is based on an opt-out system. So it's not based on consent. So when we go to the hospital, go to the GP, the interactions that you have with, data from your medical records can be, is collected and can be used for research, beyond your care, and many people actually aren't aware that this is the way the system works. And so we think there's a real risk there to public trust. And we've seen some kind of media backlash, etc., as a result of the lack of kind of clarity and transparency about exactly how data might be used. Particularly because sometimes those researchers may be from industry. And so the team that I was working in decided to try and understand what the public thinks about this, to try and inform policy and decision making. And so we ran, again, some focus groups, a national survey, and these are a couple of the findings. So we found that the majority of people just weren't even aware that researchers could access health data for research. A lot of people, 75%, thought that the public should be involved in decisions, so the public should have some kind of say in the way that data is used, which is not always the case. And 81% of people believe that the benefits coming from health data research should be shared. I think that's a really interesting point, that one, because it's what people are feeling there is that often research on data happens in the Golden Triangle, so London, Cambridge, Oxford, etc. People feel really strongly that like rural areas in the north or rural areas in the southwest should also get benefit from that data. So how do you make sure that when there are these partnerships or collaborations, the kind of insight that's developed or products that are developed are shared across the country? So that's that example.
And the second example that we'd like to share with you is about the lived experience in the Mental Health Data Prize that I just spoke about in my previous slides. So we recognize that lived experience is a legitimate and valuable form of expertise. So when we were running the prize, we involved young people with experience of anxiety and depression from both the UK and South Africa at 3 different stages of the Mental Health Data Prize. They helped us to design the prize, to design the principles, and they were also part of the selection panel to decide which teams should be funded. And now each team that are part of the Mental Health Data Prize actually have lived experience experts as participants in the team.
Okay, so onto the discussion. So in the question here is, in your experience and giving the settings, topics, issues, different geographies, different regions that you're working in, what examples have you seen about where engaging with people about the way that data has been used is done well? What ideas you have, examples? We're open to kind of creative approaches here. Yeah, we'll let you discuss. I think you already started with some ideas before. We are a little bit tight on time, so I might give you 5 minutes for this one, and then maybe continue. Yeah, like we'll be here, so we'll be keen to continue the discussion afterwards.
I think people are just leaving, basically.
Yeah, it was just being a little.
Oh, they're not. I thought people were leaving. Okay.
I was like,
no, because like they all kind of like got up, and I was like, oh, why are people leaving? I'll take the notes. Yeah. Yeah. Okay.
Wait, they've already got, maybe this one at the back?
Oh no, they spoke.
Yeah, so maybe these. Can I ask everyone to wrap up their final points? I'm going to ask probably just one group to give us a bit of feedback. Can I ask the group at the back? Shall we? Yeah, yeah?
We're literally bullying people into it.
We're keen to hear any thoughts you have. No?
Hi. Hi. So one of the issues we talked about is when certain so when you have a research project ongoing in a given community, when you tend to recruit participants within that project and you also hire from the community to sort of become inclusive. However, one of our colleagues did mention that you find that you're actually recruiting like from the same families over time, and that is essentially because the original people you recruited from the community are the ones that get to know of the new vacancies within, and so it sort of excludes other members within the community. But when they realized that, they decided to have a different approach by sending out ads throughout the community to make sure that it would reach everyone within the communities or within the families, and by recruiting workers or within the community, it sort of empowers the community as well.
Yeah, thank you. No, that's really important. Reaching out beyond the kind of initial network, but going to the like second levels. Reaching as far out as possible. Thank you. One reflection here, and then I will wrap us up, I'm afraid.
Hi, everyone. So I think giving back to the communities where you do these research studies would also be great. For example, you go and you do a study on diabetes in a certain community, and you actually figure out what the problem is. How about you go and you build a gym or maybe improve their hospitals and clinics? I think that would be a great way to show that, we appreciate you giving towards science by not just, getting papers published and getting your Nobel Prizes, but also give back to the community where you are getting all of this data from.
So basically giving
maybe,
something back to the community.
Maybe still on the same to add, it might be an infrastructure, but it might be another way of giving back to the community. And to support this, if the funders can have in their requirement that whoever does research from the community, you have a requirement of giving back to the community. It might be a way of even disseminating information and data back to them for the best use, or any other thing, but at least give back to the community. And this is a requirement from the funder, and for sure this will be done. Thank you.
Great, thank you. I think Ekin's captured those important reflections. Oh yeah, okay, go on. Yeah, go on, we've got 1 minute. I just don't want to keep anyone from lunch. That will make
Sorry,
us very
yes, I don't
unpopular.
want to. Most of the supports that everybody is talking about are basically on qualitative studies. How do you have quantitative studies have more support and engagement to the communities? Because some of the studies, we are not allowed to have their information as contact information or names or email addresses because of the surveys that we do. And we just say that we're purely going to publish this paper in a journal article, which they're probably not going to read it. How do you build in that trust with quantitative studies?
Yeah, it's a good question. As I say, I'm not the data person, so I'm not going to even pretend I've got an answer for that. But one of the things that we've tried in the past is to always try and run something qualitative alongside, even if it is just a smaller meeting or a gathering, or having somebody on the help us design the survey, or just to start somewhere. But that may well not be the answer you were after. Okay, let's carry on that conversation though. Great. I'm going to move us on. So what's next? So please give us your notes, because I realised that we didn't have a lot of time, and we want to make sure that we capture all of the kind of really important views, ideas, discussion that's come out here. So that's the first one. And then next, what our goals are is, first of all, to write up what we've heard here today, and discuss that with our team and other folks in Welcome, and how it can inform our ways of working. We want to publish a blog or article about what we've heard as well, to share the learning openly. If you'd like to have your name on it, just come and tell us, come and give us your details if you'd like to be acknowledged, but also no pressure to. And it will be, we'll anonymize everything. We're not going to have names or anything like that unless you would like to. And finally, come and carry on talking to us. We'll be at the networking session later, and you can also email us with any kind of further thoughts, ideas, questions, etc.
We are here tomorrow as well. So,
thank you.
Hello? Yes, it is on. All right. Good afternoon, and thank you for joining us for Theme Discussion 2. If you've looked on the program, you can tell that this discussion is going to be a little bit different from this morning. And to introduce myself, my name is Rosemary McKeag. I'm an epidemiologist in the Division of AIDS of the National Institutes of Allergy and Infectious Diseases. And if you know Tony Fauci, he's my boss. And my colleague, Carly Williams, is actually the branch chief of our epidemiology branch, and we will be co-facilitating this project, this discussion this afternoon. So we're going to start with a guest speaker. We have Dr. Mark Effingham. Mark is the Deputy CEO of UK Biobank. He's a physicist by background, and he earned his graduate degrees at the University of Birmingham before joining IBM in 1997, where he spent 20 years in a variety of technical, consulting, and strategic roles across healthcare and life sciences. Mark is a fellow of the British Computer Society, and he joined UK Biobank in 2016 as its Chief Information Officer. He later became the Deputy CEO in 2020. He has been closely associated with large-scale programs to add genotyping, exome, and whole genome sequencing data to the UK Biobank. And he has led the implementation of new cloud-based research analytic platform, which provides the international research community with a resource of richly curated health data. So Mark, thank you.
Okay, so thank you very much to Rosemary for that kind introduction. I've got the envious job of trying to get everyone excited after a lovely lunch, and I hope I do that through the course of the next 25 minutes or so. And really the purpose of the session today is to try and increase awareness of the UK Biobank resource and hopefully provoke some thoughts about how it can be used by researchers across Africa. So to start with some general context and background to UK Biobank for those who may not be so familiar with it. UK Biobank is a prospective cohort study that recruited 500,000 people from all across the UK in 2006 to 2010. So they came across the UK predominantly from England and small amounts of participants from from Scotland and Wales. Participants came to one of a number of assessment centres that we set up over that 4-year period. So 22 assessment centres with about 6 open at any one point in time. So we set it up, invited people in the surrounding area, and when we exhausted that local region, we then closed that one down and set up the next. And participants came and spent probably about 2 hours with us, answering a lot of information about themselves using touchscreen questionnaires, providing details on exposures around their lifestyle, environmental factors affecting their health. They provided a number of physical measures such as height, weight, grip strength, and they also provided a number of biological samples, the majority of which went into long-term storage. The only assay we did at the time was a hematological assay on fresh blood, and all the rest have gone into storage for future assays. And importantly, they gave consent to allow us to follow their health over time by linking through to health records across the UK. We're blessed with the National Health Service, which has collected historical data on patients, which we are able to access to be able to track health outcomes of participants over time, because it simply isn't feasible to have a cohort of this size coming back for regular face-to-face follow-up. Now, it's about 20 years since UK Biobank was first conceived as an idea, first mentioned in UK Parliament. And really, 20 years on, we now think it has 4 aspects that really do make it unique as a biomedical resource that's available to researchers all around the world. So the first is its size. We recruited 500,000 participants. If we had more money, we would have done more, but actually 500,000 is about the right size to be able to generate statistically powerful case control groups to allow researchers to do research across a whole range of conditions that affect us in later life. So size is one aspect. The depth and the amount of data that we collected, both as part of the baseline assessment in terms of the questionnaire data, the physical measures, but also how, since we closed recruitment, we've been turning those biological samples into additional data that researchers can use to look at associations. So from genomics through to biomarkers, such as biochemical analysis, and also imaging, which I'll touch on in a moment. Importantly, Biobank is a prospective cohort of largely fit and healthy people who joined at the time of recruitment. And it's how we follow their health over time to see what outcomes they go on to develop. That allows researchers to look at what are the environmental, lifestyle, and genetic determinants of disease. And now in 2022, we have around 15 years of health outcomes follow-up on each of those participants. And lastly, accessibility. So UK Biobank is an open access resource. We work with all bona fide researchers around the world. I've got some slides shortly which give you a sense of the numbers, but we have 30,000 researchers registered to use the resource in over 100 countries. And really, we're at the very beginning. So whilst we've been open for access for now 10 years, it's only in the last few years where usage is really starting to accelerate. And the impact of Biobank is being felt in terms of papers being published, and with 1,600 papers in the last year alone. So hopefully that gives a context about UK Biobank, and I thought it'd be helpful to give you a sense of just some of the broader data that has been added to the resource over the last 5 years, in addition to the data we collected at baseline. So Biobank was set up to look at the environmental, lifestyle, and genetic determinants of disease. And it probably is the world's most genetically characterized resource today. We took one of the samples collected at baseline, a buffy coat sample. We extracted DNA, and we undertook genotyping for all 500,000 participants. And we made genotyping data available in 2017. Since then, we've been working with typically industry consortia who have made investments in the resource to turn samples into data, and where we've added whole exome sequencing. So we've got whole exome sequences on all 500,000 participants already available to researchers, and also whole genome sequencing, where there are 200,000 genomes available today, and the remainder will be released around about this time next year. So in addition to the genomic characterization, there's been a number of other assays undertaken both by ourselves and by other research projects, such as measuring 36 analytes across a number of samples for biochemistry data. There's been a pilot for infectious disease of 10,000 participants, which we are looking to extend over the next 2 or 3 years to 50,000. And there's a project underway right now by a company called Nightingale Health, who is undertaking their NMR-based assay looking at 250 metabolite lipidomic measures, which are being added to the resource over the next couple of years. A lot of information about participants, about their health and physical measures to give us a view of the exposures and the outside of the participants. Since 2014, we've been running a large-scale imaging project where we are inviting back 100,000 of those 500,000 participants to spend about 4.5 hours with us to undergo a set of imaging measures. So MRI of the brain, heart and abdomen, plus carotid ultrasound and full body DEXA, as well as a full repeat of the baseline assessment and additional sample collection. We're about 60,000 participants through, so another 40,000 participants left to go. But we've also had funding recently committed to allow us to do a further set of repeat imaging measures of about 60,000 of those 100,000. And that starts later this year. And we'll be inviting participants back typically 2 to 7 years after their first imaging assessment to be able to look at change over time, and where we'll also get an additional set of biological samples to look at longitudinal measures. So beyond imaging, we also, as I mentioned, connect into linked health record data from across the NHS. And since 2012, we've been bringing in death and cancer data, where we have pretty much full coverage across the whole cohort. We've been linking through to hospitalization records for inpatient visits and been bringing that into the resource. And we've also been trying to get access to primary care data. Now, in the UK, that is slightly different than the likes of hospitalization or death data, because there is no single national repository of primary care data that we can easily tap into. So we've been working with kind of regional GP systems providers. So we've had access to about half of the cohort for primary care data, but we're working with government and other resources to try and get full completion and coverage of primary care data. And it's really important for a study like UK Biobank, because a lot of the research conditions of interest, you will only find health outcomes data in primary care information. So some graphs here which show you some examples around MI, as you'd expect. You typically would find that within hospitalization records and less so in primary care. But for conditions of interest such as diabetes and COPD, they tend to be dealt with more in a community setting, and being able to get access to that primary care data is really so important for Biobank, and we'll be spending a lot of focus over the next couple of years trying to get that in place for all 500,000 participants. And then just to give you a sense in terms of this context scene setting around 500,000 participants and what that means in terms of the case and control groups that you can set up for conditions of interest. And just from some of the numbers here, you can see the current observed indications of the likes of diabetes, MI, and how that will extend over time into the years ahead, and how Biobank is really positioned as a good resource to be able to do a broad range of research into the likes of diabetes, COPD, and into neurodegenerative disease. So hopefully that gives some scene setting around the data that's been there. There's been a number of additional studies we've done over the last couple of years around COVID during the pandemic, where we've been doing an imaging study. We had 50,000 participants who'd been imaged pre-COVID, and it allowed us to invite back 2,000 participants, 1,000 who we knew had COVID, and 1,000 matched controls, to be able to look at what are some of the changes that COVID had to have on the human body and internal organs. And already we're seeing some interesting research being generated from that. And some other enhancements, such as changes we've made to our access systems to try and make it much easier for researchers to be able to apply and get access to data. Improvements to our website to try and get across just the breadth of data that's there. And also the launch of our new cloud-based platform, which I'll talk about shortly. So that provides the scene setting about what UK Biobank is for those who are less familiar. I want to use the remaining part of this talk to talk about 3 areas around the access model and how research can use it, efforts that we've been taking over the last few years to look at democratizing access to the resource for all researchers, and our general approach to standards, because UK Biobank is just one example cohort within the fabric of a number of similar studies around the world and how we work together. So in terms of principles of access, as I mentioned, Biobank is an open access resource. It's available to all bona fide researchers who want to undertake research in the good of public health. And we're set up in a way where we don't provide any preferential or exclusive access. We engage with all researchers on exactly the same basis, whether they are UK or international, whether they are academic or industry. And actually, when we engage with industry parties, the first question is always kind of what's the catch? Because they don't quite understand this kind of very transparent and standardized model that we have in place, as I say, across academic and industry users. We do have a low-cost access fee, which is really cost recovery for the process of managing application reviews. We're not trying to recoup the quite considerable cost of setting up the study. So it's about £60+ million for the original baseline assessment. There's been a number of enhancements, such as exome sequencing, which is probably about $100 million investment in assays. We're not trying to recoup any of those costs. They are all there. Our access fees are very low, and it really is about how we get the resource being used by the international community, which is where the returns will come. There is a discounted fee for both early career researchers and for researchers in low and middle income countries, and we're looking at what we can do more to try and remove cost entirely as an obstacle for use by those communities. Now, we have two types of application. Most of our applications are for access to data, but we are a biobank, so we have biological samples, but they are depletable and they have a higher level of review in terms of how the biological samples are used. And we're not a typical biobank in that we don't tend to do small-scale projects of 1,000 samples here and 1,000 samples there. Our approach is really about how we turn those samples consistently at a whole cohort level into data that can be used by all researchers. So our approaches to data has been around how to do 500,000 genotypes, 500,000 exome sequences, and we typically start with a pilot project of 50,000 samples as a proof point before we move into whole cohort assays. And so our approach over the years ahead is about how we do further assays across the whole cohort going forward. So again, we keep our access costs very low. We're trying to encourage use by researchers all around the world. And we also encourage researchers to both publish their findings in open journals, but also return data that they derive so that it can be incorporated into the resource for access by other researchers. So really, the UK Biobank data set just gets richer off the shoulders of the researchers doing work with it. And again, that's a really important part of the principles about how we're being set up. To give you a sense of growth in users over time, these charts just give you a sense of the growing scale. It is almost exponential increases, both in researcher registrations, but also applications. There is a slight dip in 2021 figures because we did close our access process for a couple of months last year as we made changes to the access fee model and MTAs, but that growth is continuing into 2022. And to give you a sense of the range of research in the countries that are using the resource today, this gives you a sense of in 2016, which is when I joined UK Biobank as CIO, and when we were going through our last QQR, this was the usage. It was typically UK, US, and some research across Europe and China, and roughly half of all researchers were UK and half were international. With the release of genotyping data on 500,000 participants in 2017, that really helped to increase visibility of the resource and how it could be reused. And since then, in 5 years later, in 2021, more than 4/5 of all researchers now registering to use UK Biobank are coming from outside of the UK. I say we've got 30,000 researchers now in over 100 countries worldwide. Again, it's quite difficult to measure impact, but it's something we've been really focused on over the last couple of years. So trying to move away from simple metrics of the number of researchers registering to use it and number of applications, but trying to determine impact around the number of publications and citations, but what really are the things that UK Biobank has helped to happen that wouldn't otherwise occur. So the likes of the whole concept of polygenic risk scores really did come off the back of having genotype data available on 500,000 participants with work undertaken by Broad back in 2018. And again, as I mentioned, 1,600 publications in 2021 alone, but it really is the breadth of now increasingly prominent journals that those papers are appearing in. So democratization of resource is something that is really important to us, about how we make the resource available to as many researchers as possible. And having talked through just the increasing range of data that we've been collecting as we turn samples into data, it starts to present some interesting challenges. So back in 2016, when I joined, we were predicting around about 500 terabytes of data, largely coming from the imaging work and genotyping. But since then, we've seen these large-scale programs to turn samples into data for both exome and whole genome sequencing, and where we're now looking at a resource which is around about 15 to 20 petabytes in size. So quite a substantial growth from where we thought we would be some time ago. And that's only going to get compounded because there is increasing interest, particularly by industry parties, to make sample applications where effectively they invest in the resource to turn samples into data. They get to use it for a short period of time before it gets returned to the resource for all researchers to be able to use. Having done all of the genetic characterization with genotyping, exome and genome sequencing, and the large-scale lipidomic measures, we've still only used about 7 or 8% of samples so far. And where we're seeing interest now is about how to move beyond that genomic characterization into looking at other omics. So we've got pilot work looking at single-cell RNA sequencing for the transcriptome. We've got pilot work for both the metabolomic measures with Nightingale Health and proteomic measures with Olink, which has been driven by this industry consortium who have come together to actually invest in that resource to help turn those samples into data that we'll be able to then make available to all researchers going forward. But it is this increasing interest in going beyond genomics and adding this other omic data, and where we're seeing considerable interest around how to move the existing pilot projects for the likes of the Olink targeted proteomics assay on 50,000, how that can be scaled to the whole 500,000, but also how can we go beyond that to move away from targeted assays to more discovery-based untargeted approaches for both metabolomic and proteomic measures using the likes of mass spectrometry. And we think that is very likely to happen over the next 2 to 3 years. So if you then add that onto the existing scale of the resource, we're easily looking at 40 to 50 petabytes of data over the next 5 years. And then it really changes how we think about making that data available to researchers. So the model for Biobank that's worked very well so far has been about allowing researchers to download data to use in their own environments. But really, when you get to this scale of data at the petabyte level, you simply can't move data around. But also it's about the types of analyses you want to do at this scale requires a different approach. So a couple of years ago, we were thinking about what are the ways that we can approach this, and rather than moving the data to the researcher, how we bring the researcher to the data. And as part of the program to undertake whole genome sequencing across all 500,000, we were fortunate to receive funding from Wellcome to put in place a cloud-based platform that would provide both the environment in which we could host these data, but also the compute and analysis tools that researchers will be able to use to start to work with these data at scale. So following a procurement a couple of years ago, we engaged with DNA Nexus and Amazon Web Services so that there is a full copy of Biobank data hosted in the AWS cloud in London. The platform has been live for a period of about 12 months now, and we already have over 2,500 users using the platform today and over 650 applications enabled. So that's probably about 10% or so of the current registered user base. So it's still quite a small proportion, but it is growing steadily month on month. And we're now focused about how do we start to really turn that into a platform that is both desirable, but also desired by the research community, because it is a change management program. It's about how do we move researchers who've been used to working in their own environments and using their own tools and start to get them to use a platform environment where they may have to start to learn how to do things slightly differently to take advantage of the platform capabilities. The platform we put in place, being completely transparent, has come from a very genetics-focused background. That's where DNA Nexus's heritage is. And so for card-carrying bioinformaticians, it's a great environment that you can just get in and start to use. But actually, we have a broad range of researchers who are perhaps less technology savvy. And so we're really looking at how do we increase the accessibility and usability of this platform so that the broad range of researchers from statistical epidemiologists through to imaging users can start to use the platform to drive their research. So there are a number of things that we're doing around research credits. So through that relationship with Amazon Web Services and DNA Nexus, Amazon have kindly given us $500,000 of research credits each year that we can provide to early career researchers and researchers in low and middle income countries. That program started just over a quarter ago, and we've already given out about £100,000 worth of research credits to both early career researchers and to LMIC researchers. And we're keen to make sure that we fully consume that whole $500,000 each year. So please, if you do have an application with Biobank, please do make sure that you're taking advantage of the research credits that we can provide. We're looking at how we extend the tooling available in terms of the functionality. So moving beyond those genetic pipelines into tools that will allow researchers to work with the imaging data, with the activity data we have, and with all of the broader set of field level data. And in that regard, we've been working with DNA Nexus and RStudio to make available RStudio as a front end into the platform, which has been going really well so far, providing a very familiar interface into this cloud environment for researchers to work with the data that is all laid out at the point of access. But our real focus is about how we start to increase use by researchers who aren't using it today. And this graph here just gives you a sense that growth over time from researchers in the different countries, and where actually the use by researchers in low and middle income countries today is really very small indeed. And that's really where we're focused now, about trying to understand what are some of the obstacles that are preventing use. A third of our researchers come from the US who are using this resource. We're seeing that the kind of research you can do within UK Biobank is generalizable to other populations, and it's certainly a resource that can be used by researchers all around the world. And if you look at the current status of use across Africa, we have 30,000 researchers worldwide, but only 78 researchers across the whole of the African continent. And so one of the reasons that we're here this week and delighted to be able to come to this meeting, we also have a separate Biobank meeting that's taking place later this week to try and understand what are some of the obstacles to use. Is it around the cost of access, which whilst discounted can still be an inhibitor? But is it around just increasing the visibility and awareness of UK Biobank and providing use cases about how it can help accelerate research, even though it's from a UK setting? But also what more can we do around skills and technology enablement? And then lastly, just to focus on our approach to standards. So I mentioned Biobank is it's a preeminent biomedical resource, but it is one of a number of prospective cohort studies around the world. We spend a lot of time working with the likes of all of us in the US, with FinGen in Europe, with China Kadoorie Biobank. And really the end game, if you like, is about how we bring together this fabric of multiple cohort studies around the world that really does increase representativeness of data that researchers can then use across all of those cohorts to undertake good quality research. So we spend a lot of time with those different cohorts sharing the way that we've gone about doing things like web-based questionnaires, our approach to data curation and standards. A large part of Biobank was built when many of these standards weren't in place, and we had a lot of proprietary methods for how we coded data. We're spending time now to try and make those consistent across cohorts, looking at models like OMOP as a way of trying to standardize approaches so that researchers who are doing work across one cohort or another have lower barriers of entry for how they can consume these multiple data sets. And it really is about how do we collaborate both between those cohorts, but also with the research community to make sure that not only the data that we're providing is fit for purpose, but also the way that we provide it and the tools that we put in place actually help to generate good quality research with low friction. We've been doing some really interesting work with the All of Us team, looking at how you undertake genomic analyses across all of us data and biobank data in a very efficient way. So more on that in due course. So I'll end just with the last slide, just to say Biobank really is a unique study, given its size, its depth, the health outcome data that's already there, and how it can be used by researchers all around the world. And hopefully this has given a little bit more awareness about the resource itself and how it may be used by researchers across Africa. I'll end with a thank you very much.
Thank you so much. And we'll have a Q&A panel session at the end of the speakers. So this theme discussion is going to be a little bit different, like I said earlier, in that we're going to hear from 5 different groups that are part of DSI Africa. We're going to have 3 training hubs that will speak, 1 research hub, and 1 bioethics project. I'm not going to give you a large bio of each of the speakers, but we'll tell you who they are and what they're going to speak about. Each speaker will have about 10 minutes. They will give you an overview of their projects, and within that context may bubble up issues of data standards, best practices, lessons learned, or data access. And then we'll have the panel discussion for Q&A. So I have to say our first speaker was left off the agenda accidentally. No one intentionally did that, but he certainly prepared and was ready to come today, so thank goodness. This is Professor Tinashe Muchangwa. Did I say that right? Okay, great. He's an associate professor in biomedical engineering at the University of Cape Town with a special interest on medical imaging analyses. He's speaking for the Computational Omics and Biomedical Informatics Training Program, the COBIP. Now, I looked him up just out of curiosity and found out that he's a TEDx speaker. Not like TED Talks, but he was also interviewed for this TEDx talk. And at the end, he was asked, if you had the opportunity to sing with anyone, who would that be? And his answer was Nina Simone. So we have a mutual admiration of Nina Simone in that she and I were born in the same small little town in the western foothills of North Carolina and grew up there. So we have a mutual admiration for Nina Simone. Thank you, Dr. Dunn.
Myself and the other MPIs on our training program, and we'll touch a little bit about how we're going to be accessing health data in order to facilitate the training in our training program. So this is the rest of the team. We have Professor Nicola Mulder, who most of you should know, and our United States partner is Professor Bill Hirsch from Oregon Health Sciences University. We also have several African partners in these different African countries. So our program was born out of a realization that there's a critical need to provide a formal interdisciplinary training program beyond UCT, which would allow us to train biomedical data science as applied to data from multiple omics or multi-omics and other technologies, including biomedical imaging. Incorporated into the training program will also be fundamental and advanced concepts in machine learning and computational paradigms for developing novel Africa-specific approaches for mining African biomedical and omics data. And one of the other critical things that we saw a major need for was a need to raise awareness of career opportunities and trajectories on how skills gained in the training could transfer into a range of biotechnology and biomedical applications and avoid the curse of brain drain. So to map out career trajectories that were also attractive for trainees in the African continent. So we realized that we had expertise already local to UCT in bioinformatics, biomedical engineering, imaging and computation, and statistics. But in partnering up with Oregon Health and Science University, we were able to find a complementary set of expertise, which we could include in our training program, including clinical informatics, research informatics, and data science. So together we have developed a 2-year master's program and a 4-year PhD program. And we also have a component of faculty training where we hope to be training faculty coming from from partnering institutions from the African continent. It is our express wish that at the tail end of our project, we'll be able to have replication of the model that we have at UCT across the African continent in some form. But I wanted to be, again, a bit specific about our objectives, and then I will link up to how we're actually going to approach the training program. So our overall goal is to develop an interdisciplinary computational omics and biomedical informatics program at UCT in collaboration with OHSU. And we want to contribute expertise who will be contributing expertise in clinical and translational research in informatics and biomedical informatics. So research informatics and biomedical informatics. And so our first and primary goal is to develop the interdisciplinary graduate training program at UCT in data science. Second, that we would like to train faculty, like I said, but they would have to be from relevant disciplinary backgrounds. And in the first instance, in collaborating African institutions with the expectation to expand beyond our collaboration as the network grows. And our final aim is that we can develop an international center of excellence in computational omics and biomedical informatics, as I explained, distributed across the continent. So a summary of the tracks and where they intersect in terms of the training program. So we have all tracks would have to have a foundational knowledge of computational omics and statistics. So that's a knowledge base we're building from. They would have to have, of course, a research project that they would be working on. But then we have separation into different sub-programs for the different tracks. So for our master's program, where we expect that half of the program is coursework and the other half is a dissertation in a 2-year program, there would also be training. There would be augmented by seminars, the coursework, and then we'll be pairing the master's students with a multidisciplinary supervision team in order to carry out some training on data science for a particular research project. For the PhD, it will be more of the same, except the PhD would be expected to of course, it's a more involved program, and they would only be able to join some of the courses that are particular to the type of research that they and an identified mentor would be working on. And then for the faculty training across the continent, we hope to be able to provide some online and on-site training, and including core workshop organizations, and of course they will be welcome to participate in some of the symposia that we have with our doctoral students. So our progress to date, which is mostly on aim 1, which is to develop, evaluate, and sustain our graduate training program, is that we have a full bouquet of courses that have been accredited at the University of Cape Town in all these different areas, including biocomputing and omics technologies, supervised and unsupervised learning, which is in collaboration with the statistics department, bioinformatics programming, etc. I won't speak to all of them, but where we are not able to provide these courses at UCT, we also would have access to an asynchronous online availability of courses from our US collaborator in the following courses: Introduction to Biomedical Informatics, Clinical Information Systems, Applied Data Science and Machine Learning. And I wanted to highlight that The courses that are offered at OHSU initially offered within our COBIP, which is our training program, but from the grant, but they would be available to other UCT students outside of our training program. And the first offering of the course, which is the first one from OHSU, will be taking place in January, and we already have 8 students enrolled from the University of Cape Town. We expect that we would also allow students who are enrolling for the program, because we're starting our program in 2023 for the master's program, and we're advertising soon, to also be taking up that course and in other courses. In terms of accessing data, so the aim of COBIP is to empower trainees with the capability to develop innovative computational omics and biomedical informatics approaches using large-scale data, biomedical data sets. So we do need to find access to this data. And our approach is that we will start first with US-based health data sources, but aim to collaborate in the development of African health data sets. So some of the well-known US-based data sets that we have identified are the MIMIC, I don't know how to pronounce this, the NANES, or the National Health and Nutrition Examination Survey, other health data from the US government, NCBI, and an upcoming newly funded program called Bridge to AI, which our US collaborator is also involved in. Of course, we're also looking locally to see if we can identify some African health data sets. And one of the options that we're considering is partnering up with the Western Cape province to have access to the provincial health data center, which could also be a rich source of data. The challenges, and of course, as being part of the consortium, we would also hope that within LWASI, we would be also able to find some access to some data as the platform grows. And the challenges that we expect, of course, what everybody expects, which is privacy concerns, quality of the data, which will need to be evaluated. And if we're using synthetic data, how are we managing with regards to clinical realism, etc. So that's sort of me touching on the health, on the accessing data part, and that was our program. Thank you.
Thank you so much. Our next speaker is Professor Celestine Twizzer. He is the director of the Center of Excellence in Biomedical Engineering and eHealth, and his project is harnessing data science for health discovery and innovation in Rwanda. Beautiful country. If you ever get a chance to go and you haven't, definitely visit.
Thank you. Yes, thank you. Good afternoon, everyone. I'm Celestin Twizzer from the University of Rwanda, and I want to share with you the progress on the research training program in data science for health in Rwanda, in collaboration with Washington University in St. Louis and the African Institute of Mathematical Sciences in Rwanda. Sorry. So the acronym is DST Hirgwa. Hirgwa means happy, and I want to wish for everyone to be happy here in Cape Town. And thanks to the organizers who really chose a beautiful period, and hope that everyone here is happy. So this is the team from our collaboration from the Washington University in St. Louis. Here there is somehow when you say University of Washington, that is not the right name. So it is
Washington University in St. Louis, because we have also in collaboration with University of Washington in Seattle. So, and this is a collaboration between Washington University in St. Louis, University of Rwanda, and African Institute for Mathematical Sciences in Rwanda. The objectives, the first one is to develop and refine competencies and model curriculum in data science for health, with the major area in computer science and informatics, statistics and mathematics, and the biomedical sciences and the public health. The second one is to recruit and expand a diverse group of well-trained data science for health trainees. This is in terms of master's, PhD, postdoctorate, and junior faculty. The third one is to develop a robust training program with a focus on didactic, research, proposal development, career advice, and mentoring. And the fourth one, to evaluate the training program by trainees and by program faculty. And the fifth one, to develop a program transfer and long-term sustainability, where Washington University as the main lead will be transiting the administration and leadership to from Washington University to Rwanda. For milestones for year 1 and year 2, the first one is data science for health curriculum development, trainee recruitment, identification of data set and research project for trainees. This is already done. This for year 2, recruit and enroll first cohort of master's, PhD, and postdoc trainees. The bootcamp involving grant and manuscript writing skills, career advice, research and academic advance topic in data science for health and care, healthcare, data management, bioinformatics, statistics, epidemiology, communicable diseases, and others. And at the same time, small research project preparation, completion, submission, and the website development. For the recruitment of trainees, in terms of masters and PhD in first year, now this slide show the numbers of applicants, and this show the needs and the potential candidates in terms of candidate to embark in this data science for health. In terms of gender, age, the age is between 30 and 40. In the field of area of computer, data science, informatics, mathematics and statistics, biomedical sciences, public health, and the nursing. And in the criteria to admit them, we have top 5 percentile and between 6 and 20. And for now, we have recruited the first 7 master's candidates and the 4 PhD students. Those are already admitted trainees in terms of PhD, where we have 25 representation of female, and hope that for others they have more than this percentage. During this consortium meeting, we are talking about data generation, data sharing, and some difficulties to even access those data. And in collaboration with our partners, we are thinking on how to use synthetic data for training, but also for research. So we have submitted under the UE5 this proposal, the Synapse Synthetic Health Data Platform for data science training. And this is under the funding opportunity on access, harnessing data science for health discovery and innovation in Africa, research education program. And we have 3 main objectives where we have to develop and refine competencies in the use of synthetic health data, deliver a mentored, hands-on, immersive, semester-long research project experience using synthetic health data, and evaluate short-term training program and semester-long research projects with an exploratory objective to determine dissemination and long-term sustainability for Rwanda synthetic health data. The partners in this proposal, we have University of Rwanda, Washington University, EMS, DSI Africa Consortium from DSI Africa Law, DSI Africa on Computational Omic and Biomedical Informatics Program, MD Clone, who is the software company, with an involvement of Rwanda government officials, because without them, it will be difficult to implement this project. So we have the Minister of Health, we have the Director General for National Institute of Statistics, we have the Rwanda Biomedical Center Director General, and we have the Executive Secretary for the National Council for Science and Technology. Those are the main government institutions to implement this proposal. Now, as the previous presenter was saying, we need to democratize access to computational derived synthetic data. How it is work? We have, sorry. Yes. We have at we have the real patient, number of real patients, and through computational techniques and methods, you reach on the similarity of the data from patients, but having anonymizing them and without any human subject need to work with those data. At the end, you have the synthetic data derivative, where you are maintaining the statistical properties of the original data and do not correspond one-to-one with the original patient. This is a preliminary study with our partners, as I was saying, Washington University in St. Louis and University of Washington in Seattle, where this paper is around the National COVID Court Collaborative with the analysis of original and the computationally derived electronic health record data, where the main funding is to demonstrate that computationally derived data had same and similar statistical output at the original data set. In terms of boot camp, we are planning to have this with those kind of topic, an immersive boot camp in order to train those candidates in competencies on data science for health. Challenges, success, and lesson learned. For the challenges, and as you know, I want really to congratulate the organizers that at least today we have a non-in-person meeting, but sometimes the online meeting in terms of communication breakdown and some administrative delays between institutions. The success is that we have already recruited initial master student and PhD. We have applied to other research opportunities, and we have successfully set up a training program. The lesson learned is that we are meeting frequently, and we maintain the open communication at all time, and we have set up a communication process and a governance structure and shared leadership. Thank you very much.
Thank you very much. And yes, there is a University of Washington in St. Louis and a University of Washington in Seattle. So we're going to, oh, Washington University, sorry. Anyway, all the names. We're going to be hearing from UWash in Seattle on our next project. So we have Dr. Christy McKinney. Christy McKinney is an associate professor in pediatrics and epidemiology in the School of Medicine and Oral Health Sciences at the University of Washington in Seattle. Her topic is going to be on our third training program, Data Science for Child Health Now in Ghana, or DS Change. Now, this particular training program reflects her particular interests in young children with oral and craniofacial conditions. Her research interests include nutrition, growth, early feeding, and environmental exposures in high and low or limited resource countries.
All right, I had to do a double take when I arrived 2 days ago because I saw a gentleman saying Washington University, and I was like, wait, do I know that person? And they're actually somebody from the Wash U in St. Louis, so it's easy to get us mixed up, and I don't think we'll take offense. It's a pleasure to be here today to talk about the DS Change program. So basically, I'm just going to give you a quick overview of the program and then and talk about a partnership that we have and what that means in terms of data access. So the training program aims for DS Change are pretty standard. I think the first is to train an interdisciplinary group of scientists in data science, students, masters and PhDs, and to also build capacity in the faculty at Kwame Nkrumah University of Science and Technology in Kumasi, Ghana. I think one of the unique aims is really trying to focus on developing team science fluency, and we are working on all three currently. So in terms of our trainee degree programs, we'll have 3 different areas in biomedical data science, in public health, and imaging, and computational biology. There'll be a master's and a PhD program. These are currently under review with the Ghana Accreditation Board, and we expect to start our first cohort in January. We also are doing a number of activities to help our faculty translate their traditional areas of expertise into data science. So we have faculty exchanges. Our first is actually starting next week, where we have between KNUST and University of Washington faculty who will come and see different examples of biomedical data science that we're doing at the University of Washington, sit in on data science classes to see how they're taught, and meet with a variety of faculty doing a variety of work in imaging, public health, and computational biology. We also have opportunities for faculty to attend the University of Washington Institutes in Biostatistics, which has a module on data science, and then certificate programs as well that are available to faculty. Our training focus is on child health, and we have these 3 primary areas of disease areas that we're working in. So one is malaria vaccine development, another is injury. And what I'm going to focus on today is talking about cleft and the data source for our cleft studies. So we'll be looking at cleft outcomes as well as cleft etiology. So what is a cleft? A cleft is a type of congenital anomaly. It's one of the most common anomalies around the world. It affects approximately 1 in 1,000 live births. Varies a little bit by area of where you're from, but it affects everybody globally. And it occurs in the first trimester of pregnancy, and it affects the lip as well as the palate or the roof of the mouth, which doesn't form in a typical fashion. And what this means is that these children, from the moment they're born, have many challenges to traverse to a healthy, productive childhood. So this starts with their ability to eat, to feed properly, and to grow so that they can actually have the surgical repairs that are required to repair the cleft. There are often issues with breathing, speaking, hearing, so it requires a very multidisciplinary team to care for these children. And as you can imagine, with having a facial anomaly, that it has major impacts on the quality of life and the psychosocial status of mothers, families, and communities. So we partner with SmileTrain for our data for our trainees. SmileTrain is a nonprofit. They're based in the United States. They've been in existence since 1999, and they support cleft rehabilitation in over 90 countries. They think currently they're in 70 countries and low middle income countries around the world, including many in sub-Saharan Africa. Their focus is on safe, quality cleft care, and they're really focused on supporting local clinicians to do the work. So their model is not bringing in a group of American trained clinicians to do cleft repairs, but rather to support local providers to do the work, and so that families have a place to come back to, they have a home where they can get the care that they need. And how they do this work is that for every child that receives a surgery, there's a record that's created for that child. And that record includes all of the clinical care that those children have received. And that record goes to what's called the STX, or the Smile Train Database, which has been in existence since 1999. And so for every single child, they have a variety of health and surgical information, as well as photographs. So a child is photographed before their surgical repair and then after for each surgery that occurs for each child in each country. And with that information, that's how providers, whether it's a surgeon, an anesthetist, the cleft team, there's nutritionists, those services are reimbursed to the providers by submitting a record. And so the programmatic database that SmileTrain has includes over 3 million images of children who've had cleft repair, 1.5 million records of surgical interventions, and there's about 19,000 records that include nutrition, orthodontics, or speech. And it's not widely available. SmileTrain is very particular in terms of who they share their data with. I should have meant to start off with the fact that Prof. Donkor, who's a PI of the project, and myself both sit on different advisory boards for SmileTrain and have had, particularly Prof. Donkor, a longstanding relationship with SmileTrain. And then one of our authors here is a SmileTrain employee. So we definitely, kind of talked to her about this talk. And I think one of the things they're very passionate about is local empowerment. And so they were really excited to partner with us so that DS Change trainees would actually be the ones to analyze this data. So it's a unique data source, one of a kind. I don't know of any other congenital anomaly data sets that are this rich, expansive, or extensive. And because of that, I think there's high potential impact. I think what the question that we're sort of, I think, starting to wrestle with, our trainees will start in January, so we haven't really had this issue come up, but it's the FAIR principles, and how do we think about the FAIR principles in terms of this data resource? So to remind everyone that FAIR is findable, accessible, interoperable, and reusable. And I don't have lessons learned. I have sort of more considerations or questions and things that we're currently thinking about, which is how do FAIR principles apply to data such as the SmileTrain data that we don't own or manage? And then how do we balance leveraging this one-of-kind resource to actually trying to optimize what are areas that we can comply with, with the FAIR principles, and how do we do that? And then what are the legal and ethical considerations that perhaps we haven't thought about as a training program that are related to this partnership? So that's perhaps something we can talk about in our group. And then these are our training program partners that we're working with. So that's all I have for today. Yeah.
What a rich opportunity. I have many questions, but so now we're going to switch to a research hub. We're going to have Professor Lashley Abimaku, who's going to be our primary speaker, and she's going to be joined with her co-investigator, Cheryl Baxter. So Dr. Abimaku is going to speak. She is the executive director of the International Research Center for Excellence, and this is at the Institute of Human Virology at the University of Maryland. And she's going to speak about the role of data streams informing infection dynamics in Africa, or the INFORM project. And Cheryl is currently the head scientific support at the Centers for Epidemic Response and Innovation at Stellenbosch University. And as I said, she's a co-investigator with the INFORM Africa Research Hub and a member of the Data Management and Analysis Core.
Thank you. Thank you for inviting us. Good afternoon, everyone. Good afternoon. Yeah. We're in Africa, we usually respond back. So, yeah, we're going to do a tag team and just give you a brief outline of what we're doing in our own research hub, which addresses the role of data streams in informing infection dynamics in Africa. And for our research hub, we have we have 5 MPIs. I lead the group, and the prime is Institute of Human Virology, Nigeria. Most of the PIs, all 4 PIs have been here, and please take the time to meet with each of them for each of the projects. So I lead the overall admin and the research hub. Vivek Narabai is leading our project 3, which is, he comes from Caprisa. And Tulio, who was with us earlier on, leads our DMAC. And we have Dr. Baster here, who would give you an outline of what we've done so far. Man Chararat, who is also in the audience, lead Project 1. And Shimfane, also in the audience, who is an engineer among us, leads Project 2. So our general goal is really to use national large database that can inform future epidemics. So use that as a cornerstone. And we've used that in 3 projects, and I'll describe the 3 projects in a little more detail in the next slide. And we have 2 cores. So we have the administrative and the DMAC core. And what we do with our industry partner is to have them help us develop geospatial tools that can be used with country leadership. And our research hubs has involved the governments of Nigeria and South Africa, whom we're working with, and in looking at specifically HIV infection, large data streams of HIV infection, and COVID-19 as well in the 2 countries. We hope to expand some of the work that we're doing through pilot projects as well, and we will hope to develop a tool that will be available to governments in these 2 countries, but as well as other relevant countries in Africa and the rest of the world. So just briefly, Project 1 aims to use geospatial distribution and phylogenetics of SARS-CoV-2 to identify key contributors of infection and transmission within social networks. So, and then Project 2, which is led by our engineer, is using mobility data. So they use the platform of looking at human movement through mobility and how that has affected transmission and also affected some of the interventions that have been in place, for instance, in the area of COVID, and see whether those interventions have actually impacted on human movement and in subsequently infections. And then Project 3, what we try to do there is to look at the effect of an incoming pandemic on an existing one. So in this case, for the individuals that are infected with HIV in South Africa and Nigeria, to look at the effect that COVID has done on those individuals that have those infections. And then hopefully through our pilot projects, what we hope to do is expand, and we're very lucky to have a supplement already that helps us to expand what we're doing and to see the effects of climate change, for instance, in even movement and transmission. And then we hope to also expand to additional pathogens if it's relevant and other countries. So we hope that through engaging with investigators at this meeting, we'll be able to expand that. So I will end with just describing our structure, and just to say that our research hub is governed and managed by the steering committee, and to point out that the governments of both countries, especially those that are custodians of the large national data sets for COVID-19 infection and HIV-2, are an integral part of our steering committee. And they've been with us from the beginning of the submission, where we've got letters of support, but we've continued to engage them to ensure that we have access to those to those data that would use. I've already described the projects. I've described the fact that we have DMAC, and all of that interacts through our DMAC to the bigger DSI consortium. But I must acknowledge also the incredible support we've gotten from our LSI group that have advised us in terms of some ethical concerns and how we engage the community, and of course our scientific advisory board. But since we're talking about data science, I thought it would be useful to have a more in-depth description of a DMAC core that is run by Tulio and Dr. Baxter, who have really done a great job in organizing our research hub and putting that together. So, Dr. Baxter.
Right, good afternoon, everyone. So my job in this part of the talk is to give an overview of how our DMAC supports effective data management and analysis across the Inform Africa project. But because this session is also about lessons learned, we wanted to reflect a little bit about what the challenges and lessons have been in us trying to access the data to do our work. And just want to mention that I'm here on behalf of the rest of the team. It's a large team, so I'm just here representing the core. So just a brief overview of what the DMAC and Next Generation Sequencing Core's mandate is. Our main goal is to provide a data management platform so that the projects can work seamlessly together. And we have 4 aims. The first one is to develop a scalable platform where the data can be coordinated and all the tools and workflows and components can be combined. And then to provide access to the data sets, so in a shared space. And then also, because we have a lot of experience with genomic sequencing, the other mandate of our core is to leverage our Omnics experience to create an NGS analysis platform that will be applicable to the wider groups. And then we provide some training and support. So just looking at what the landscape looks like. So we are gathering a range of data types, all sorts of data ranging from genomic data, mobility data to epidemiological data. And these data types come from a number of different sources. So we include national public health institutes that have been collecting large quantities of data on both COVID and HIV. So we're collecting data from both South Africa and Nigeria. So we have different government sources. We are also collaborating with private individuals like Discovery Health, medical aid. And we also have a number of open source data sources that feed into the pipeline. And then obviously the sequencing data that comes from GISAID. All of this data is stored in our local servers, and where the data is cleaned and harmonized. And the long-term plan is to deploy it into the Terra platform. And so that's where we are now. So this is just an example of all the different data types that can be integrated to answer questions about whether it's outbreaks or predicting new infections. So this is relating just to our genomics data. And in South Africa, we have about 45,000 genomic sequences for SARS-CoV-2 and about 6,000 from Nigeria. These data can be combined with patient metadata, such as sampling date, gender and age, other things like comorbidities, but we also can compare what we have to global information that's available. But the important part is linking the genomic data and the epidemiological data. So data available on cases, deaths, etc. So just to end with some of the lessons learned, and I want to focus just on 3, which is in data access, complying with local legislation, and then the sharing of the data. Lashley has already mentioned the importance of our stakeholder engagement and making sure that we engage with the providers of the data, particularly the governments, and from the onset, they were involved in the application, providing letters of support. They're part of our steering committee. The members, representatives from the different stakeholders sit on our community advisory board, and some of the members of the community advisory board are also on the in the LC groups. But despite the support from high level in government, we need to have ongoing meetings and communications with the stakeholders to build trust with the stakeholders, and just to introduce the projects, but also to ensure the providers of the data, the confidentiality, all sorts of things surrounding how the data will be used. But none of the data can be accessed until we have ethics clearance, and we needed to get ethics approval from 4 different ethics committees for this particular project, from Nigeria, from the US, and 2 ethics committees in South Africa. Working with private health sectors, they are also reluctant to give data, so we've found novel ways of working with them by getting just sample data from them, and then we write scripts so that they can analyze the data on their side, but it requires a lot of backwards and forwards and communication and refining the scripts to get what we're needing. Just the point on the compliance with local legislation is that all of the data we are accessing is de-identified, so we're not able to link personal identifiers. But this creates some challenges when we're trying to link different databases of COVID and HIV. So this creates a issue with the suppliers and the stakeholders are willing to collaborate with us and give us the data, but when and those that have both sets of data, we're asking them to link it on their side, which adds a burden to them. So it's a lot of backwards and forwards working with the stakeholders, but we've also found novel ways of linking data without identifiers. For example, we have hospitalization data from COVID, but we've been able to link the sequencing data using the episode number, which is not linked to any identifiers. So we've been able to create some links like that. And then just lastly, in the sharing of data, the DMAC is both a recipient of data, but also a provider of data, because we're the platform that is the link between the data suppliers and all our projects. So this means we need to have multiple data transfer agreements in place. The platform we were trying to share through Terra, and we encountered a couple of challenges with the billing and things, so we had to set up some alternate ways to ensure we can share the data. And just, and this is probably a universal challenge for everyone, is that the data is in different formats from the different suppliers. So that creates a bit of a challenge. So it's something that we will have to problem solve. So I just want to acknowledge the funders, but also this is a large team that worked together on this project. So I've put up the different institutions that collaborate together on this project, and all the individuals, and then all our main collaborating partners, which is the Department of Health, both here in South Africa and in Nigeria, and Discovery Health, our private medical aid. And just to say thank you.
Thanks. I'm a little biased about that project. I'm the scientific officer for them. But I really look forward to every phone call that we have because they present the work that they're doing. It's ongoing work. It's a lot of fun to talk dynamically about questions that they have and issues that they might be dealing with some of the data and even with some of the findings. But this is a really dynamic group. So our next speaker is Professor Simisola Akintola. She will be speaking on bridging gaps in the ELSI of data science health research in Nigeria. She is a professor of bioethics and health law at the University of Ibadan. She's also a faculty member at the Center for Bioethics. This must have been a statement that she wrote, and it's very colorful and creative, and it says exactly what we know. Her research is motivated by the yawning gap between technology, medical science, and the existing regulatory framework. The yawning gap. We see those in a lot of areas. So come on.
Thank you, everybody. I hope by the end of this presentation, I would have deserved that. Project. And it's a project that is basically around evaluating governance frameworks for data science health research in Nigeria. And we are working with stakeholders to develop novel governance frameworks. And like my drive for this work is to find a solution to the yawning gap between technology and the law. And data science health research has provided that opportunity. The aim one that we are working on at this point in time is to aggregate, analyze current frameworks for oversight of data science health research in Nigeria. And in doing that, we examine laws, policies, guidelines, and frameworks relevant to all aspects of the ethical conduct of data science research, including old collections, paper collections, storage, manipulation, analysis, everything we could lay our hands on data science in order just to aggregate what the Nigerian position is legally on data science health research. So my presentation is going to take this form: the introduction, accessing health data, the legal and ethical considerations, and considerations for accessing health data, which I believe is what everyone wants to hear. So, looking at the left-hand side, I'm talking about promoting health research and protecting personal data, which is like the push and the pull of the issue. We want to promote health research and we want to protect personal data. However, as technological capabilities for data acquisition and computing increases, the types and sources of data used in health research and the ability to link data from multiple sources have expanded, bringing with it the baggage of different associated levels of ethical and legal concerns and considerations. With this, we discovered from the research that most of the laws do not address the ownership of health data. At best, what they do is guarantee the data subject's rights, security of personal data, privacy and access rights. This presentation will provide an overview of the laws on accessing and stewarding data, the tensions and conundrums raised by them in the context of data science health research. Now, these are the legal considerations for accessing health data from the Nigerian data processing law. Accessing data, we know, has its utility. And unfortunately, increased access simultaneously increases the risk of privacy infractions. These are what we know. But how or what is the law that we have on hand do about it? The NDPR, which is the Nigerian Data Processing Regulation, provides for the rights of natural persons to data privacy, the security of data by imposing a duty of care on data controllers, data stewards, making them accountable for breaches arising from their negligence. From the little that I have said, I'm sure you have an idea of the issues that this kind of law has for researchers. Consent is one of the limitations, or we consider limitations, on accessing data. But as much as it may be a limitation, it is still the protection. And for most African countries, at least for Nigeria, I can say consent is still a prerequisite. For human research that we've always known, we understand why consent is necessary. But for data science, health research, it does create a problem. So one of the reasons why we're here is how to overcome that problem. At the same time, have the privacy, confidentiality of the data subject in place. On the other hand, issues of the ownership of the data too is another thing. How far? The right to data portability and access to data or copies, the right to adequate information, all these are contained in the NDPR. But when we look at it, if such rights are there, for the data science health researcher, it creates a problem. But I must remind you that the NDPR was created not for health research. It's a commercial law. It was to protect the Nigerian business environment, and that you can see from the preamble. These are the National Code of Health Research Ethics. When people talk about the robustness of the Nigerian law, it's because of the National Code of Health Research Ethics. However, the code did not have data science health research in mind. The code was birthed after the Pfizer scandal, so it was for human research, no doubt, but it did not have data science health research in mind. It notes that for research to be ethical, there must be respect for potential and enrolled participants. In data science health research, who are the enrolled participants? Participants' right to privacy may not be needlessly compromised. It talks about needless compromisation. How do we define needless compromisation? The law does not define needless compromisation. There's no other piece of legislation that uses this phrase, and there has been no judicial interpretation of needless compromisation. So it's a wide, it gives a wide latitude to interpretation. It says that participants must know that their involvement is voluntary and they can withdraw at any time without penalty. For those of us who are custodians of data, I am sure you know that this unlimited right to withdrawal can be problematic, but that is the state of the Nigerian law. However, data samples already contributed to the research up to that point may not be needlessly withdrawn, as this may jeopardize the scientific validity of the research and become unjust to those who remain in the study. So it's just presenting the conundrum and the challenges that are in the extant Nigerian law. This is our findings, and that's what I'm presenting to you. Ethical considerations for accessing health data involving data subjects in decision making about their data. While most of our laws do not apply specifically to data science health research, like I have mentioned, the ownership of this data have been considered in some ownership of data, not health data. I should have mentioned that in the previous slide, had been considered in some judicial interpretations, and they are interesting. But as interesting as they may be, it is the law. It talks about the house number, images, that it is possible for you to own that data. In contrast to what you have as a custodian of data, it would create problems. These decisions predate, like I keep reminding us, data science. It predates what the kind of technology we have in place. But until those laws are changed, those are the laws that we have in place. If you take a look at the posters that we have downstairs, they thematically present our findings. It isolates like about 6 laws that are tangentially on data science and their findings in relation to the themes of privacy, ownership, access, stewardship. About 7 themes. We couldn't put everything on a poster, but we identified 6 or 7 main themes and how the laws have some provision and how we have interpreted those provisions. So the ethical considerations is involving data subjects in decision making about their data, community engagement, approval from health research ethics, and data security. On data stewardship, these are the laws that we have. We have the NDPR, the National Health Act that Professor Alesh mentioned, the National Code of Health Research Ethics Code, the National Code of Medical Ethics, the Nigerian Constitution. And the case I was speaking about, one of them is MTN against NIA. You can have an idea when I say MTN, it couldn't have been data science or Portland Paints. But all the same, they related to data. Our takeaway is that there is no specific law delineating the ownership of health data. In Nigeria, courts enforce consent before use principle. Data sharing is permitted with conditions. We've just established the Nigerian Data Protection Bureau to enforce compliance on lawful use of data. Lawful use, as we have said, is as I have highlighted. Like I said, I'm representing the Bridge LC team. Professor Ogundiro and Professor Adebamowo, that I'm sure you all know, are the MPIs on this, and this is the team that we have worked with. We are working, I want to extend my gratitude to the Center of Bioethics and our collaborators, the University of Maryland, the George Washington University, another Washington, and of course the DSI Africa. Thank you very much. Of course, the National Institute of Health.
Now, I hope you've written down some questions. We're going to start our Q&A panel discussion session. So if all the panelists would please come up, and my colleague, Dr. Williams, is going to facilitate this part of the discussion. Thank you to all the presenters. That was excellent.
So I need a microphone, although I've been told I have a very loud voice, so but I won't go through on the web. There's a question already in the back. Thank you for amazing presentations to all members of the panel. Regarding the presentation from the NHS, from the UK Biobank, now I know that you have a very detailed consent form, and you made it very clear that there is no discrimination in terms of access to data by commercial entities as well as public sector institutional researchers. There is a very clear statement in your consent form that in the event of commercialization, the data subject or data donor has no claim to any profits or any share in terms of profit that may be generated. Now, we've done some empirical research in South Africa, and participants here feel that they are willing to donate samples. So the particular study was about samples, not data. So they're willing to donate samples, but if there is any commercial gain, they would like a share in the profit. So I'd just like to know what, in terms of the UK population and your donors to UK Biobank, has there been any empirical research, and what is your experience? Are people just happy to share their data with commercial partners and not be, not receive part of the profits? Thank you.
So it's a very good question. And I just say it was a clear part of the consent form and the information kind of leaflets that participants read and agreed to before joining UK Biobank. We maintain contact with participants over time. So to your question around empirical kind of research into views, there hasn't been anything kind of formulated, but we do maintain contact through regular newsletters. Obviously, we invite participants back to Biobank to take part in studies. And when we engage with them through the newsletters, we do take care to explain exactly how the data is being used by particularly kind of commercial organizations. And a really good example is when we had the first example of Regeneron and GSK, which was two large pharma coming together to fund the initial exome sequencing of 50,000 participants. We were careful to engage with participants ahead of time to set out the rationale for why they were doing that and why this is actually a positive thing for the resource and for the research community in general. And we've included subsequent engagements through newsletters when we've had similar kind of projects. When we did that and a kind of engagement, we did have a small number of participants get in touch to try and understand more about how industry were using it. But on the whole, it was generally very positive feedback. We had a very small number of participants who, this was 10 years on from the original consent and participation, who felt that actually at that point in time, they never, no longer felt it was appropriate. But it was literally a small handful of 2 or 3 participants out of 500,000 that we wrote to. And we're seeing that kind of continue through subsequent engagements where we've done further work using the resource with industry investment, and participants seem to be generally relaxed because it's how those industry go on to develop new therapeutics, new interventions, which will actually improve health for all, and that's really kind of the goal and ambitions of Biobank.
Thank you. A question here?
Hello, I'm Donrich Thaldar. So regarding benefit sharing, my suggestion is that it should be a debate, an ethical debate about fairness and equity, because if you just ask people what they will all want money, but wanting something is not necessarily sufficient ethical reason. Then from a legal perspective, in South Africa at least, it is unlawful to benefit share with the providers, with the donors of samples. It is not only unlawful, it is a criminal offense to offer them any form of financial payment or any other kind of reward is a word that is used in the law. So that's completely out of the question, at least in the South African context. My question is for Dr. Baxter. Dr. Baxter, I'm very interested because you mentioned that the data is de-identified. So of course, that's not a legal requirement. That's more a way to avoid legal compliance and avoid PUPIA. So the concern always with de-identification is in the event of an incidental finding, do you have any plan in place to be able to find the relevant research participant? Thank you.
No?
Yeah, no.
Yes, hello, okay. So how we will use this data is population level, showing patterns, and it's not going to be linked back to an individual, but it will be more patterns that we're seeing higher rates of adverse outcomes in individuals who have HIV versus those that don't. But it's not going to be an individual level outcome, if you understand. So it'll be more population scale and not an individual level. Yeah.
Yes, up here. I think if you start talking.
Yes, thank you. This should be going to the ESLI, but it concerns all of us. I have a security background, and we are talking about de-identification and etc. The current research that is hot is reverse engineering to actually identify participants back from the data that is de-identified, and this is crazy and of course scary. With our partners at MIT, actually they are looking towards moving to no downloads, but work in the cloud on the data. So I think we need to have a discussion on this, download the data versus work on it in the cloud, because most of the approaches now that we're discussing is availing the data to people to do analysis to it, but how this is done, I don't know how Terra does it, if people are supposed to download the data and etc. So it is a point that is really catching up. And most of the biases in AI and machine learning, people are trying to do research to identify these possibilities. And yes, from my background, at some point it is possible to reverse engineer and actually know that this is so and so from this area, as long as the descriptors of the data show that this is collected from Ghana, this is collected from South Africa, and etc. Thank you.
So does someone here want to address that? The use of the cloud as a data safety measure to prevent inappropriate re-identification. And so to me, this has been something I've been thinking about with data sets that we hold, that if you can watch what people are doing analytically, it's helpful for data security. But I don't know if any of you have considered that. Most of you are doing cloud-based analysis in your training, or do students download data?
From a biobank perspective on this, I think it's clear that the download model that we've had, and there's a number of levels of protection in place around only engaging with bona fide researchers. Researchers enter into material transfer agreements that guide how they should use the data and security controls, and explicitly that they shouldn't try to re-identify individuals. And we also have de-identification protocols across all of the data so that each application gets a uniquely pseudonymized set of de-identified data for their purpose. And being able to have researchers download that and use it within their own environments, I think has really helped contribute to the success and the outcome findings from Biobank to date. I think it's driven a lot of that wide-scale use and a number of applications we see. But I think there is a balance around the emergence of platform access to data, where you can actually bring researchers into an environment and you can have greater controls around security, around auditing. That's definitely a positive thing. But I think it is about how we ensure those environments are the places that people want to come to, that actually allow them to be able to innovate and be able to work with those data to generate new findings. Has to be at the right kind of pace so that we don't kind of prevent research, but we do it in kind of lockstep.
So I was appreciated our studio, and that's getting to a, it's not Python, it's a much more accessible, and I think hopefully we'll be able to move in that direction. You have a question, sir?
Yes, I'm a bit curious because my questions is to a curiosity to Dr. Celestin Tizeri from Rwanda. Yes, when he was presenting the program, realized that people applicant for PhD seem to perform less than those from the master. I will see something like 30% were less than average, but they were applied for PhD. What can explain that? Now, another one is a comment, a more general comment, about the benefits of research. Usually what we see in many of our countries is that when the patient go to the hospital, he pay, but the data that are generated, the patient never benefit from the research. But this issue, I did not see people really raise that issue. That seemed to me very important because patients are financing the health. We are doing research, but we don't think about how to compensate it somehow.
Question about bringing data back, bringing answers back to patients and how to do that. I noticed that as well about the Rwanda data, and then I noticed that the graduate students were mathematics and statistical students, and I thought, they're getting graded on their masters, when their masters are getting graded on their undergraduate work. That was my guess. Who presented? Was that your data?
Right.
It was yours.
Yes.
Yeah, I think maybe
Can you hear me?
Mm.
Yeah, the less number of PhD applicants, and I don't think it is less, because 70 PhD candidates at the level of PhD, this number is really huge. And you're supposed to select 4 among them. It is a competitive selection with at least 3 steps, where from the 3 steps, you're supposed to select 4 candidates. And note that this is, there is a limitation. Perhaps you can say Cameroon or Nigeria or another big country, you'll be funding 500 or 5,000 applicants. But the research training is limited to Rwanda. Is limited to Rwanda, and those candidates or the 70 applicants, they are from Rwanda for the data science for health in Rwanda.
Is there any hope you'll be able to accept more at some point? Your acceptance rate is very low. You're very picky. You're only like 1%.
This depends on the fund availability.
Talk to Roger. Roger's very interested in funding.
Yes.
Sir? There with the... Oh, okay.
Thank you very much. Dr. Mark, thanks for the presentation. I wanted to hear more about the participants' health status at enrollment. I heard you were following up and ask them questions about their health. But at enrollment, we are all healthy or some were sick, stuff like that. I wanted to be clear on that. And secondly, on consent, I wanted to hear your experience in UK. Consent in Uganda is a little bit complicated. First of all, I heard you say you consent participants for follow-up. Then I wondered, don't you consent them to participate at that point in time? Then thirdly, you said you do genetic testing. So I wanted to know, is there a specific consent for genetic testing? Is it part of the broader consent? Because in my country, the moment you say you will do genetic testing, then it's a special kind of consent.
So there's a few questions in there which I'll try and answer. So I guess Biobank is a prospective cohort study of largely fit and healthy people at the point of recruitment. So we weren't trying to identify people who had conditions. We actually wrote to 10 million participants from all around the UK, and we had about a 20-to-1 kind of acceptance ratio to a letter that goes out to say we'd like to take part in this study. The only requirements were that you had to be aged between 40 and 69 and be registered with a GP. And again, the consent is a single consent, so there isn't a separate consent for any subsequent assays or determinations we do. It was a single consent at the point of joining the study itself. So it is I would say a slightly healthier representative cohort than the UK. You do see some of that in data. There is a certain amount of self-selection bias. So people who want to be involved in these kind of studies probably do tend to lead slightly healthier lives. And that's one of the things you need to take into account when you're kind of researching with it. You look at AF rates within UK Biobank, it's about half of what you may see within the general kind of community, if you like.
Let me ask you one question now. How long does it take to do the consent?
So the consent is very straightforward. It's part of the touchscreen kind of questionnaires in the baseline assessment. So obviously in advance you send out the materials, the information leaflets. You need people to be able to read those, to be able to ask questions. But it's literally a few minutes at the start of the study, and a participant couldn't continue through the assessment centre clinic visit unless they'd actually consented.
Okay, so quite concise.
Thank you very much, Mark. My question is for Mark. It's about access to the UK Biobank. Okay. You say you charge an access fee. So how do we make this equitable? I'm coming from Africa, from Nigeria. Maybe my daily income is less than $1, and everyone is on a flat rate to access that data. I'm not sure it's that equitable from my own understanding. That's one. And two, you showed us a graph, indicating the number of people from Africa that had access to the data. I think it would be also be important maybe to get back to those people that access the need for the access. I mean, if 74 or so is coming from Africa, where maybe up to like few days ago, I got to know about the UK Biobank and the accessibility, maybe due to awareness, maybe even be due to need. If I don't need access to, if I don't need those data, I may not be able to, I may not have any need to access it. And the third one is around the recruitment that you did. I noticed that many of the participants came from England, while few came. Were there any sampling method that you used for that, or?
So again, a few questions in there. So we took a lot of effort to try and get a representative recruitment of participants from across the UK, getting a good mix of kind of socio-economic background, of age, of gender, ethnicity. And so it's broadly representative of the UK population at that point in time. Obviously, that's a transient kind of point of view. 20 years later, it is slightly different. But the kind of research you can do around associations between exposure and disease are generalizable elsewhere. Your first question, can you just say that what that was again? So in terms of the equitable access, so it's a really good point around, we do have access fees, which are the same whether you're an academic or industry, whether you're UK or non-UK. We do have discounted fees for early career researchers and for researchers from low and medium income countries. So right now, depending on what data you want to access, the typical charges are between £3,000 and £9,000, which is a lot of money, but that does provide you access to several £100 million worth of sequencing data and similar. Now, for student researchers and LMIC researchers, we have a discounted rate of £500, which is a small fraction, but we know that is still an obstacle for access. The way that Biobank has been set up, and this is kind of an issue around tax reasons and similar, we are legally obliged to charge a fee. We can't just provide no access. So in the same way that we've been engaging with industry, who've actually coined this model of effectively co-investment, they're investing to help turn samples into data for the benefit of all. We've been talking to those same industry users to say, can we put in place some kind of grant fund that could actually then be drawn down by LMIC researchers? And that's something that we're investigating right now. There's been a lot of positive feedback, so that we're hoping that in the near future, we'll be able to actually advertise the existence of such a fund that researchers will be able to use, so that effectively for researchers in low and medium income countries, it's effectively negated.
That sounds fantastic. We have a question over here.
No, thank you. I have two questions. One is for Alashi regarding the work you're doing looking at HIV and the intersection with COVID-19, which I think is extremely important, especially when we think about some of the results from this country when we started to look at mutant variants and what that might mean in populations where HIV is a big problem. I don't know where that science is going right now, but my question is really quite specific in that as we do the science, a lot of people have talked about what are we giving back? And I'm asking whether, given the low coverage of vaccination and the uptake of, whether you're making a deliberate effort that the people that you're testing actually have access, if they are negative, to COVID vaccine, if they are not vaccinated, and if they are found positive, whether you're making some allowance for them to access treatment, especially if they have underlying HIV disease. I'm just asking about that. Then the second point that I wanted to ask is related to the study in the UK. I see that you have a huge data set, which is really great, but only benefiting adults. And I'm wondering why no children, especially if we're worried about diseases of the future with everything that we're experiencing with climate and everything else. Why no children? I just wondered why you made that decision not to include children.
So let's start here.
Actual data. Oh, yeah. Thanks very much for that question, really important one. And one that really talks about, like you say, giving back to the community. And if you're working with government, it's a very important aspect to do. So right off the bat, a lot of the data that we're working with are already existing data. And the idea, especially for Project 3 that looks at the intersect between COVID and HIV, is to see some patterns that could make these individuals more vulnerable and be able to share that with government. Now, one of the, and I believe it's our first project, we're actually putting out questionnaires to understand whether these individuals have been vaccinated or not, and what are the enablers or inhibitants of them getting vaccinated. And this is data really that we're sharing again with government to make sure that some of the policy takes into cognizance some of these vulnerable populations, because this is what we're seeing, whether they're vaccinated or they're wearing masks. One, we're able to share with them in terms of the mapping of the transmission and to really provide that information on whether this is an area where there's high uptake of whether it's mask or vaccination or not, to be able to do something about it. Fortunately, a number of us investigators that are also in data science support a number of these programs. And one of the things that the US government has allowed us to do is try and educate individuals as much as possible so that they understand the safety issues surrounding vaccinations and why they should get some more. So really what we're trying to do is create those kinds of patterns that enables the provider to give better services to the community.
And really quickly, I think also the issue about children, we're sitting on a continent where 60% are below 25, and you haven't enrolled.
Very simply, Biobank is set up as a study to look at common diseases that affect us later in life. There are other studies which have recruited children, Auspac study in the UK, for example, and that 40 to 69 kind of time point was just recognizing you want people to age and develop conditions, and that's a reasonable time frame for the resource to become valuable quickly.
Well, we're at time. I think we've discussed a number of points that I would love to talk further. Someone mentioned brain drain and the process of training up new people and then holding them within data science and health and not losing them off to industry and high salaries. And I think that will remain a challenge for us. And another theme that I heard over and over again is really building trust, building the relationships and partnerships with government, with data owners, with the community, this conversation back and forth to ensure that there's value back to the people who participate in our data, even though we almost always are looking at large data sets and don't really have individual results, but we can educate about what benefit we bring to community. So some of the other things that came out on this, and so much work to do to increase access to data and make it available to all, really democratizing data and ensuring that it's fair. So let's give these presenters a nice hand, and thank you so much. I think it's a break now for networking, yes?